Rasool, a PG scholar from the Department of Ilmul Amraz, and it's my privilege to be your host today as we embark on this journey of knowledge, inspiration, and collaboration at this National Conference on Ilmul Amraz. As the great Albert Einstein once said, the only source of knowledge is experience. Today, we bring together a wealth of experience, brilliant professionals, passionate researchers, and dedicated scholars, all united by our shared mission to delve deeper into the mysteries of pathology and advance the boundaries of medical science. This conference is not merely an event, it's a celebration of progress, a forum for innovation, and an opportunity to redefine the future of healthcare. With groundbreaking research, transformative ideas, and powerful partnerships on the agenda, we set to make waves of the in the worlds of Ilmul Amraz. So let's begin this exciting day with energy, optimism, and purpose. Before we dive into the scientific session, let's begin with the inaugural proceedings to set the tone for this extraordinary day. First, I invite our distinguished chief guest, Dr. Ramesh Krishna K, Dean and Director, Bangalore Medical College and Research Center, Bangalore, to kindly join us on stage and take their esteemed seat. Next, let's extend a heartfelt welcome to our beloved Professor Ghulamuddin Sofi, sir, Director in Charge NIUM and Chief Patron of this conference as he takes his dignified place on the stage. Now, I warmly invite Professor Abid Ali Ansari, sir, HOD Department of Mahitul Amraz and Organizing Chairperson of this conference to join us on the stage. It's my pleasure to welcome Dr. Sadique Ali Ansari, Sadique Ali, sir, Associate Professor of Department of Mahitul Amraz and Organizing Secretary of this conference to take his privileged seat on the stage. Finally, I welcome Dr. Renuka B.N, pathologist at the hospital laboratory and organizing secretary of this conference, to her honored place. Thank you, sir. Thank you, madam. As we begin, let's seek the blessings of Almighty for the success of today's event. I now invite Dr. Mir Uzair to recite a few verses from the Holy Quran.
Assalamu alaikum wa rahmatullah. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. والضحى والليل إذا سجى ما ودعك ربك وما قلى وللآخرة خير لك من الأولى ولسوف يعطيك ربك فترضى ألم يجدك يتيما فآوى ووجدك ضالا فهدى ووجدك عائلا فأغنى فأما اليتيم فلا تقهر وأما السائل فلا تنهر وأما بنعمة ربك فحدث. I seek refuge in Almighty Allah from the accursed shaitan. In the name of Allah, the most merciful. By the morning brightness and by the night when it covers with darkness, your Lord has not taken leave of you, O Muhammad sallallahu alaihi wasallam, nor has he detested you. And the hereafter is better for you than the first life. And your Lord is going to give you, and you will be satisfied. Did he not find you an orphan and give you refuge? And he found you lost and guided you. And he founded you poor and made you self-sufficient. So as for the orphan, do not oppress him. And as for the petitioner, do not repel him. But as for the favor of your Lord, report it. Assalamu alaikum.
Thank you, Dr. Uzair, for the heartfelt and soulful recitation. Your words truly have set a serene and auspicious tone for the day ahead. Now, I call upon Professor Abid Ali Ansari, sir, HOD Department of Ilmul Amraz, to take the stage for a welcome note.
Assalamu alaikum. Very good morning to all of you. Bismillah Rahman Rahim. Honorable Chief Guest, Dr. Ramesh Krishna K, Dean and Cum Director, Bangalore Medical College and Research Center, Professor Ghulamuddin Sofi, Incharge Director, National Institute of Unani Medicine, Organizing Secretaries of this event, Dr. Sadique Ali and Dr. Renuka B.N, respected speakers, distinguished delegates, esteemed colleagues, and dear students. It is my immense pleasure and privilege to welcome you all to the National Conference of Ilmul Amraz, Pathology, hosted by Department of Ilmul Amraz, National Institute of Unani Medicine, Bangalore, in collaboration with Bangalore Medical College and Research Center. Ilmul Amraz, pathology form the cornerstone of classical and modern medicine, bridging the gap between clinical practice and research by providing clinical insights into disease, diagnosis, prognosis, and treatment. This conference aims to bring together pathologists, researchers, clinicians, and academicians to discuss the latest advancement in our field, share knowledge, and foster collaboration that will shape the future of pathology. This conference reflects our collective commitments to classical and advancing diagnostic accuracy, improving patient care, and embracing new technology. We have an exciting program lined up with eminent speakers who will share their invaluable expertise on topics ranging from ancient era to modern scientific advancement. To all our delegates and participants, I hope you find this conference enriching and insightful. Let us use this platform to share ideas, ask questions, and explore innovative solutions to the challenges we face in pathology. Once again, I warmly welcome all of you. Let this conference mark the beginning of new partnerships, deeper learning, and meaningful advancements in the pathology and laboratory medicine. Thank you, and I wish you all a productive and successful conference. Thank you.
Thank you, sir, for your welcoming and encouraging words. As we extend a heartfelt welcome to our esteemed guests, we are delighted to present each of them with a sapling. This gesture symbolizes our deep appreciation and warm regards, embodying growth, harmony, and flourishing bond we share. To begin with, may I invite Professor Ghulamuddin Sofi, sir, Director in Charge NIUM, to kindly present sapling to our chief guest, Dr. Ramesh Krishna K, sir. Next, I warmly request Professor Abid Ali Ansari, sir, to present a sapling to Professor Ghulamuddin Sofi, sir, Director in Charge NIUM. Let these saplings symbolize our shared commitment to foster growth, spread positivity, and celebrate lasting relationships. Thank you. Now it's time to hear from our esteemed dignitaries who have graciously joined us today. True leaders inspire through their words and actions, leaving a lasting impact on those who guide. Let's Let's welcome Professor Ghulamuddin Sofi, sir, our respected director in charge, to share his invaluable insights with the audience. Please, sir.
Assalamu alaikum and good morning to all of you. Respected Dr. Ramesh Krishna K, Dean cum Director, PMC and Research Institute, Bangalore. Professor Abid Ali Ansari, sir, Head Department of Ilmul Amraz, Department of Ilmul Amraz, and Dr. Sadique Ali, sir, Organizing Secretary of the event. I am truly honored to present before you this synopsis or presidential address for Mahithul Amraz, though my specialty is Ilmul. When we call up this Mahithul Amraz, what it is, we have a very much long evolution of this subject. We have developed this, established this department 5 years before. When it was set here, we had scarcity of the faculty, so they were patronized by Kuliyat, Department of Kuliyat, and well, it was fortunate for them that they started their department under the guidance of Kuliyat, which helped them to organize the fragmented literature of Unani medicine about Kuliyat. But basically, when we talk of this pathology, we say it is etiopathogenesis, establishing the legend for disease, and then seeing the manifestations of the morbidities. If we see ICD-11, when we say about the diseases, they have not restricted diseases as disease entities, which we study in the books. They say about the complications, the disabilities, and other things separately. This reminded me of Galen when he was trying to define the disease. On defining the disease, he told that it is a continuum from health to disease. And in the continuum, we have several terms. Say, for example, we have the intermediate states and we have disabilities of the disease and we have handicaps also. And all these terms, they are not just separate categorical terms, but they are a continuum from disease to health. This evolution from Gallen, who tried to state what disease is, book on pathology of disease, he states that we cannot define health and disease in concrete terms. They can be only defined in a type of states which manifest like the normal or abnormal functions. Then Ibn Sina stated about it that we can say total functions are deranged or some functions are deranged. And when we came across Ibn Sina, then or later our physicians, they told that we may have 3 states or we have other various things. But here the contribution of Galen is very important. What he did an interdisciplinary study. Whatever the books he wrote, he had the incorporation of the organon of Aristotle, and then Alchemion's distinctive states or individualization of method. And then he stated one more thing which was very important, the Hippocraticum's book, or we call Hippocraticum. Corpus Hippocraticums, which transmitted to Galen, maybe they are false or they are other books which are not authenticated, but they came to Galen, and then we see that the observations of Hippocrates, the organon, the structure of organon or the logical dealing of Aristotle and Alchemion's categorical statements, it helped Galen how to state things. Whatever the terminology Unani medicine has, among them, what the book from Harvard, it states that almost all the evidence-based medicines or traditional-based medicines or systems of medicines, they have borrowed almost 65% of the terminologies from Galen. Then what we say, what Ibn Sina did, what Razi did, they refined all these concepts. Say, for example, Aristotle states that there are 4 causes, 4 natural causes, which are very much necessary for existence of a phenomenon. And Galen is talking of epiphenomenon, symptom and signs. Ibn Sina is talking of phenomenon, that is observations, how we logically state observations and see the relation between the two observations. Again, Razi is stating another different thing. Say, for example, he states in his book, Kitab al-Farik, he says that we have the same type of bole tibni, or amber-colored urine. It can be because of the causes, pathological causes of liver, or it can be because of the pathological causes of kidney. And then he goes on to differentiate between the bole tibni caused due to the causations in liver or pathological state of liver. And then he again states that what is the difference between the bole tibni, which has been formed because of the pathological state of kidney. Not only this Razi, he has mentioned almost what I read, 30 diseased entities, how to differentiate them on the basis of urine, on the basis of pulse, and on the basis of compulsions, and on the basis of site of morbid material. So this is not a small thing, but this has been written in 10th century AD, when there was no microscope, when we had no means of assays, when we never knew what enzymes are. Still, we had all these things, how we differentiate diseases, how we call a disease category, what is a complication, and what are the causes. He differentiated them. And then all our physicians, all our pioneer scholars of Unani medicine, they prioritized it. They said cause comes the first, then observation is there, then there are the sequela of the observation. What we say, cause, disease, and complication. And these are not small things in the evolution of medical sciences. But when we say holism, holistic medicine, it has taken a different direction in traditional system. And our conventional system, our conventional system work in today, it has taken a different direction. The reason is the incorporation of technology and reductionistic methods, beating up an observation into pieces and then connecting them back. We call it reductionism. But holism is a different thing. We say that we take the observations and then we want to take something which is very much different towards, which is very much different, and all these parts are not equal to the whole, but whole is something more than the parts. So when these two philosophies are compared, say Unani and modern medicine, we are not saying that they are opposite to each other. They complement each other. That is very important, which we have to know. Because we are talking of reality. We are talking of facts. Facts never change. If we talk of a fact through Unani prism, we say that we have symptoms, we have observations, we have signs, we have patterns. And we take all these symptoms, signs, patterns, and collate them together and get a factual figure. And when we talk of conventional medicine, they want that the disease should be diagnosed or that its cause should be located, and they go through blood examination, they examination, they go all other CT scans or other things. And they say that now this is this disease. Again, when I say the fact is same, reality is one, then it should be necessary that they should complement each other. They should not have a difference. The Unani thing should not be a different thing than the present conventional medicine. So this needs that we should have an integration. Where this is the point where we say integration is necessary. When one feels that Unani looks at reality from one thing, observation, patterns, causes in its own framework, and we say that in conventional medicine we have all the necessary tools to go through the microscopic description of disease. We need an integration. For that integration to go up, to take up this integration, we are trying to see methods. Today, even we have this conference, it has been specified that it has been focused on certain topics which are very much interrelated, and we don't see it. It is very much vast. They are very much integrated, and they have been taken in a sequence so that we can see the scope of integration of these two philosophical aspects. When we integrate them, we can collate them and see how far we can go integrating these concepts. So message of this conference, which we shall take, and we shall learn a lot of things from Unani, from conventional medicine, but the message should be that there are certain common necessities which we call the pillars for integration. That should be taken up so that we can work towards the actual integration, not the integration of all the systems under one roof. That is one of the administrative way of integrating it. Not the integration in the way that we use a microscope and see a disease, and then we don't want to collate it with the Unani philosophy. It is not the integration, but it is basically coming together, just coming together. Say, for example, two students which are very much different in their approach, they come together, sit in a hall, it don't interact with each other. That interaction is needed. And when we go for these type of conferences, we have to discuss these things. When we discuss them, then there are certain things which we may get as very important messages. And I congratulate Department of Ilmul Amraz who have given us this opportunity that we can sit together and discuss about this Ilmul Amraz and then see how much the aspect of pathology, modern pathology, can be integrated with Ilmul Amraz. And I hope this will prove a milestone for the Department of Ilmul Amraz and NIM. Thank you very much.
I request all the delegates to take the front seats. Please, everyone, take the front seats. Thank you, sir, for your visionary and motivating address. With great honor and profound respect, I now invite our esteemed Chief Dr. Ramesh Krishna K to grace this gathering with his enlightening words and address the audience. Please, sir.
Very good morning to all of you, respected dignitaries on the dais, Professor Ghulamuddin Sofi, Incharge Director, Professor Abid Ali Ansari, Dr. Renuka, Dr. Sadique Ali, Organizing Secretary, Dr. Abdul Azeez, Dr. Azizur Rahman, Dr. Tasfiya, Hakeem Ansari, and all the dignitaries, other dignitaries, respected dignitaries on the dais, and dignitaries of the dais, and guest speakers who have been invited here today, distinguished faculty. I would like to thank the director and management of this institute, the National Institute of Unani Medicine, and the Department of Atul Amraz Pathology for inviting me here today as chief guest and making me part of this program. So this conference, today's conference is the National Conference on Ilmul Amraz Pathology organized by the National Institute of Unani Medicine. It is in collaboration with our esteemed institute, the Bangalore Medical College and Research Institute. So myself, for the people who don't know who I am the Dean and Director of Bangalore Medical College, and I have been also the former principal of Bangalore Medical College. I'm the Dean since last 2 years now, and I have been the head of the Department of Orthopedics since last almost 10 years, and Medical Superintendent of Victoria Hospital for 4 years. And I have given all my service since last 33 years in the Department of Orthopedics and in Bangalore Medical College, Victoria Hospital. So we're also happy that we have done a lot of work during COVID, and during all the 3 COVID waves, I was the medical superintendent of Victoria Hospital. And I am proud. I'm here happy to share that I'm proud that the Department of Pathology has been doing excellent work in BMCRI in Victoria Hospital campus in the Infosys lab, and under Dr. Sadique, who is the head of the Department of Pathology. And of course, we have also been doing a lot of Unani work in Victoria Hospital, and thanks to Dr. Renuka, who's here, who's supporting us. So today, it's a matter of pride, privilege, and honor for me to be part of this program. So this conference is for the advancement of pathology. For encouraging the faculty and the staff and students for doing such good work in this institute, and also for training the students. I would like to congratulate the organizing committee, the faculty, and the staff of the Department of Atul Amraz Pathology for bringing together all such experts, many experts in this field, and for furthering the course of science and healthcare. My suggestion is, sir, we should have more such conferences and CMEs for the betterment of the institute as well as for the department. To conclude, I'm sure in the presence of such esteemed guest speakers today and invited faculty, who I'm sure are very well renowned and highly experienced, and the delegates and the staff and the students of this institute present today will have a great academic discussion for sharing knowledge in pathology and laboratory medicine, and share innovations and also ignite collaborations today and have a great learning experience. So my other suggestion is whatever conferences, whatever CMEs will benefit only if it is interactive. So whatever doubts, whatever questions anybody has, they should come out, and discussion should happen during the course of the teaching. So once again, I would like to thank all of you for making me part of this program, and I wish this conference is a grand success. All the best. Thank you very much.
Thank you, sir, for your thought-provoking and inspiring words. Your achievements and experiences are truly impressive and inspiring. At this moment, I request our Director in Charge, Professor Ghulamuddin Sofi, sir, to present memento of gratitude and appreciation to our Chief Guest, Dr. Ramesh Krishna K. Please, sir. Thank you, sir, for doing the honors. Now I invite Dr. Sadique Ali, sir, to deliver the vote of thanks and set the stage for today's day ahead.
Hamidan wa musalliyan amma ba'd. Assalamu alaikum and good morning to everyone. On behalf of the organizing committee, it's my privilege and honor to propose a vote of thanks as we conclude this inspiring inaugural session. First and foremost, I would like to express our deepest regards and heartfelt gratitude to Honorable Chief Guest, Dr. Ramesh Krishna, Dean and Director, Bangalore Medical College and Research Institute. Sir, your presence here today is a great honor for us, and we are deeply grateful for your valuable time and the wisdom you have shared with us. I wish to convey my heartfelt thanks to our Director in Charge, Professor Ghulamuddin Sofi, sir, for his encouragement and guidance, which have greatly contributed to the organization of this conference. I take the opportunity to express our heartfelt gratitude to our esteemed Director, Professor Syed Shah Alam, sir, who unfortunately could not be here with us today due to official tour. We deeply appreciate his visionary leadership and unwavering support, which have been instrumental in making this event possible. I also express my heartfelt thanks to former Director in Charge, Professor Abid Ali Ansari, sir, who initially approved this conference. I am deeply grateful to Organizing Chairperson, Professor Abid Ali Ansari, sir, for his tireless effort and dedication in making this event a vibrant and collaborative platform. My special thanks to the Organizing Secretary, Dr. Renuka B.N, and Coordinators Dr Abdul Azeez, Dr Azizur Rahman, and Dr Tasfiya Hakeem Ansari for their seamless collaboration and efforts in managing various aspects of this event. A heartfelt thanks to all distinguished speakers, delegates, and participants who have gathered here to make this conference a vibrant and collaborative platform. I also thank all HODs, faculty members, RMO, and clinical registrars for their guidance and support in shaping the conference. A special appreciation goes to our students for their passionate participation in making this event a grand success. I also thank wonderful anchor, Dr. Ishrat Rasool, for her exceptional efforts in gracefully steering this session. Last but not least, I would also like to thank the individuals who work behind the scenes to make this event a reality. A special thanks to the volunteers, especially the PG scholars from the Department of Mahidul Amraz and the technical and supporting staff without whom this event would not have been seamless. As we forward with the rest of the program, let us carry the spirit of the learning and collaboration inspired by this session. Thank you all once again for your presence, support, and encouragement. Thank you.
Thank you, sir. Thank you so much for your warm and uplifting remarks. At this moment, I kindly request everyone to rise and join in the national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
With this, we officially conclude the inaugural session and step into the heart of our program, the scientific session. Let the pursuit of knowledge guide us and as we explore new frontiers and unlock the potential and scientific innovation. Ladies and gentlemen, the stage is now set for today's intellectual exploration and discovery. Our program features expert talks, trailblazing research presentation, and thought-provoking discussions designed to address the most pressing challenges in pathology and healthcare. Today, we will explore innovative diagnostic approaches, discover new frontiers, and build the foundation for the healthier tomorrow. So without further ado, let's commence the first session of the day. Honored attendees, as we begin our journey of discovery and learning, we are thrilled to introduce a session that seamlessly connects the timeless wisdom of tradition with the cutting edge advancements of the modern science. We are privileged to have with us the renowned Dr. Syed Azizullah Hussaini, Assistant Professor, Department of Mahitul Amraz, Government Unani Medical College, Chennai, Tamil Nadu. His good self will share his insights on topic scientific perspective of Unani diagnostic tool, the Lyle Wall, in the diagnosis of renal diseases. This session is poised to unveil fascinating insights into how Unani principles can be harmoniously integrated with contemporary diagnostic techniques, offering innovative approach to renal health. Dr. Hussaini is a distinguished scholar in Unani medicine, celebrated for his contributions to revive traditional diagnostic tools and aligning them with the needs of modern medicine. It is with great pleasure that we welcome Dr. Syed Azizullah Hussaini, a renowned and respected expert in the field of Unani medicine and a passionate educator, researcher, and practitioner. A scholar with a strong academic foundation, Dr. Hussaini has earned MD from prestigious Nizamiya Tibbi College, Hyderabad, and his BUMS from Government Unani Medical College, Chennai. Over the years, he has made significant contributions to advance Unani medicine through his teaching research service. His efforts have been recognized with multiple awards, including gold, silver, and bronze medals in competitive seminars. As a prolific writer, Dr. Hussaini has authored and co-authored research articles in reputed journals and has written books and therapeutic guides such as Al Risala fil Nabz, a treatise on pulse, and 36 regimes of Unani medicine in therapeutics. His dedication extends beyond academia as he actively contributes to community health through NSS programs, rural health camps, and awareness initiatives aimed at promoting Unani medicine. Please join me in extending a warm and enthusiastic round of applause to welcome Dr. Syed Azizullah Hussaini, sir. Sir, we invite you to take the stage and enlighten us with your expertise.
Respected dignitaries, and dear professors and teachers, and dynamic PhD scholars and delegates of various institutions. Assalamu alaikum wa rahmatullahi wa barakatuhu. And very good morning to all of you, ladies and gentlemen. First of all, I'm very much grateful to Almighty Allah who has given me this opportunity to speak few words in front of you. In the name of Allah, the most beneficent, the most merciful, I would like to express the gratitude to the organizers of this event who invited me and gave me this opportunity to present this topic. That is scientific perspective of Unani medical diagnostic tool, the Dalai Bol, in the diagnosis of renal diseases. As you know, Unani diagnostic tool, there is Dalai Bol. It is a very old and ancient concept, and that is very much scientific, and that can be very much correlated with the modern scientific aspect of urine analysis. And urine was the first laboratory test performed in the medicine and had been used for several thousand years. Today, urine analysis continues to be the powerful tool in obtaining crucial information for diagnostic purpose in the medicine. And the Dalai Bol, which is called indicator signs of urine in Unani medical diagnostic tool, which is described by the ancient Unani physicians since before the period of Hippocrates, who was the father of Unani medicine, 460 to 377 BC, for the assistance of diagnosing physiological as well as the pathological conditions of the body. And urine was used as a primary diagnostic tool. Dawood Antaki stated that these Adil al-Bol, that is indicator signs of urine, are categorized into 7 types according to the modern Unani physicians. As the ancient Unani physicians, they included another 2 Adil al-Bol, that is tactus and taste, that is excluded by Avicenna. And this classification is totally based on the experimentation and observation. As you know, these are the various diagnostic aspects in Dalai Bol, that is Alvan al-Bol, Tiwam, Raiha, then Safai wa Kadurat, then Miqdar, Zubda al-Baul, Rusub al-Baul, that is sedimentation or deposits of urine. Allama Ali Jilani narrated that urine may be of 5 colors. The classification of urine colors is based on experimentation and observation. That is Bol al-Asfar wa Tabkhatuhu, that is yellow color of urine and its shades. Then Bol al-Ahmar and its shades, Bol al-Akhzar, then Bol al-Aswad and Bol al-Abyaz and its different shades that can be easily evaluated, and that signifies to different pathological conditions. Before going to that, we must know the variations in urine according to body temperament. In Har Mizaj, we can find reddish or dark color urine, which will have a strong smell and high density. And in Barid Mizaj, usually the color of urine will be white or colorless with decreased smell and low density. In Ratam Mizaj, usually the color will be white or colorless with decreased smell and high density because of its moistness. In Yabis Mizaj, usually the color will be darker and it will have higher density. And according to Abu Sahil Nasihi, this variation in urine can be because of domination of a specific body humor, like domination of sanguineous humor, in which we can find dark yellow color or reddish color urine, which signifies heat, and high density, that signifies moistness. And in domination of phlegmatic humor, usually the color of urine will be white, that signifies coldness, and high density signifies moistness. In domination of choleric humor, usually the color of urine will be darker and fiery, that signifies extreme heat, and it will be of low density, that signifies dryness. And in melancholic domination of humor, usually the color of urine will be black or reddish, greenish black, that signifies coldness in the body, and it is of low density, that signifies dryness. Now we'll see the different shades, which is described in yellow color urine, like Bole Tibni, Bole Utraji, Bole Ashkar Naranji, Bole Nari, and Bole Zafrani. These are the different shades which can be seen experimentally in the patients. And it always signifies to different body conditions. For example, Bole Tibni usually signifies to cold body temperament. And apart from that, the Bole Utraji, that signifies the equable temperament, that is the normal body temperament. And after that, the all shades mentioned in after Utraji, that is Bole Ashkar Naranji, Bole Nari and Zafrani, all this signifies to hot temperament. And it may have some physiological as well as the pathological causes. For example, in physiological causes, this higher intensity or higher darker color of urine, like Bole Ashkar Naranji, Nari and Zafrani, that can occur because of overactivity or strenuous exercise, or extreme fatigue condition, or it can be because of starvation or hunger, or dehydration, or it can occur in so many pathological conditions like colicky pain, inflammatory conditions, and different condition in which the bilious humor and the sanguineous humor will be dominated in the body. According to Burhanuddin Nafis, all these degrees of yellow color will be due to domination of bilious humor because of madda sabiqa, that is called urochrome or urobilinogen, which is excreted through the urine. Then Bole Ahmar wa Tabkhatuhu, that is red color urine and its shades, in which we can see Bole Ashab, Bole Vardi, Bole Ahmar Khani, and Bole Ahmar Akhtam. It is of 4 shades. As we know, all these conditions are because of frank hematuria due to presence of large amount of RBCs and hemoglobin in the urine. According to Unani classics, all these red color urine points towards the domination of sanguineous humor, and some of these color influence the body heat. And some of the conditions like insufficiency of liver and insufficiency of kidney, like zoophilia, we can find smoky red color urine that is called bole ghosali. And sometimes this red color can also be present in cold temperamental disorders like hemiplegia, sleeping sickness, zoalkinia, and in which the quwwat mumayyiza, that is selective power of selective reabsorption in kidney, that will get damaged. And sometimes in cases of acute abdominal colic, like urinary obstruction, can also lead to red color urine. Then bole akhzar wa tabkhatuhu, that is green color urine and its shades, in which we can find bole fistaki, bole zanjari, bole asman juni, bole nilaji, bole kurasi, and bole zaiti. These are the different shades. Among these, bole zaiti is included here in green color urine, but it comes under complex color of urine. Among these, bole fistaki usually indicates to cold temperamental disorders, and bole zanjari and bole kurasi usually indicates to combustion, that is ihtiraq of bilious humor and melancholic humor. And apart from that, bole asman juni and bole nilaji usually indicates to cold temperament conditions, as well as the ingestion of some toxins. And you can find this bole zaiti. It is of two types. That is called bole zaiti zubani and bole zaiti ghair zubani. In bole zaiti zubani, usually that is due to some dissolutions or atrophic conditions that happens in the body. Bole zaiti ghair zubani usually occurs in case of dyslipidemias, in which the oily urine can be found. Then bole aswad wa sabkhatuhu, that is black color urine and its shades, in which we can find bole aswad zafrani, bole aswad akhtam, bole aswad akhzar, and bole aswad abyaz. And usually these all black color urines produced by combustion of bilious humor and melancholic humor. And bole akhtam, aswad akhtam usually occurs due to combustion of sanguineous humor. And bole aswad akhzar usually occurs in combustion of melancholic humor. So that usually that results from some combustion in different humors, like combustion of bilious humor, or combustion of sanguineous humor, and combustion of melancholic humor. Then bole, these are the different shades which I have shown here. Bole aswad zafrani, bole aswad akhtam, and bole aswad akhzar. Then I will describe the different shades. Yeah. White color urine and its shades. Bole abyaz wa tabqatuhu. Here we can find bole abyaz mushaf or majazid, transparent white urine, and abyaz haqiqi, that is absolute white urine. And this bole abyaz haqiqi, it is classified in different shades. Bole abyaz mukhati, bole abyaz dasmi, bole abyaz ihali, and bole abyaz fiqai, bole abyaz manvi, and bole abyaz rasasi. So all these different shades of white color urine signifies different pathological conditions in the body. Oh, sorry, I'm getting some disturbance in my leg. Can I able to sit and present this topic. Sorry. For some time I will sit and then I will stand up. Sorry for the inconvenience.
Please share screen properly.
So these are the different white color shades which we can see. And these different shades usually indicates to different pathological conditions. Bole apias moshaf, that is also a pathological type of urine, which indicates cold body temperament and also indicates presence of phlegmatic humor in the body. And it is also seen in various pathological conditions like diabetes mellitus, polyuria, and hepatic insufficiency and renal insufficiency like zoophilia and altered temperament of the liver. And appears haqiqi, that is absolute white color urine, in which you can see bole khailusi and bole labni. And bole khailusi usually indicates to chyluria, which can be seen in filariasis and obstruction to the lymphatic channels, and any metastatic condition which is causing obstruction to the thoracic duct. And bole labni, that is galacturia, that indicates some hyperparaxial condition of the body. And lymphatic disorders, which can occur in bowel field and other metastatic condition to the thoracic duct, and its obstruction can lead to this bole apias haqiqi. So here you can see the different samples of bole apias majazi and bole apias haqiqi, and bole labni and bole mukhati. So bole mukhati is significance. It signifies to excess of crude humor, that is immature humors in the body. Then chronic phlegmatic disorders. And apart from that, bole ihali, that is waxy color, waxy urine, that indicates liquefaction of adipose tissue, that is called lifuria. And it usually seen in acute hyperparaxial fever and tuberculosis. And bole dasmi, that also seen in liquefaction of serous humor. And it also seen in chronic cachexial disorders like malignancy and chronic infection like tuberculosis. Then bole fiqai, that is seen in ulcerations in the renal parenchyma. And bole manvi, that is because of seminal emission. And it is also seen in some crisis of inflammatory conditions. Then bole rasasi. Regarding this, ancient Unani physician mentioned that bole apias rasasi usually signifies to some toxins, ingestion of toxins. If there is no sediment in the urine, that usually causes some morbid condition. Then bole labni, that is milky white color urine, that indicates some obstruction in the thoracic duct or any injury to the lymphatic channels. And any other malignancies which is affecting the lymphatic channels. So these are the different shades of white color urine. Then we will discuss the complex color urine like alwan murakkaba, in which you can find bole ghusali, that is raw meat washing color urine. Then bole arghani, that is purple color. Then bole badkan, violet color. Then bole khamri, wine color. And bole himsi, that is chickpea color. Bole middi, that is purulent urine. Then bole urine. Then bole jambi, that is pale color. Here you can see the pictures of different shades, that bole ghusali, then bole middi, that is totally purulent urine, and bole khamri, that is reddish wine color urine. As you know, bole ghusali, it is commonly seen in insufficiency of liver and kidneys, in which the quwwat mumayyiza, that is power of selective reabsorption, is totally damaged in the kidneys due to chronic kidney disease. And apart from that, the insufficiency of liver, in which the liver parenchyma are not in the position to detoxify the byproducts and mature the humors. In that condition, we can see the bole ghusali. And in case of chronic kidney disease, that is insufficiency of kidney, zoophilia, in starting 2 stages, there are 4 stages in this disease. In starting first and second stage, usually the urine will be bole tibni. And in 3rd and 4th stage, usually the urine is of bole ghusali, that is coffee ground color urine. Then argoni or purple color urine, it indicates combustion of bilious and melancholic humor, and it is also found in pleurisy, and sometimes it occurs in morbid conditions. Then bole badkan or violet color urine, that also indicates combustion of sanguineous humor and melancholic humor, and it is commonly seen in pleurodynia, that is shows up. And bole khamri or wine color urine, that is signifies to combustion of sanguineous and bilious humor, and if it occurs in inflammatory condition of the viscera, that indicates to bad sign. So these are the different colors and its physiological and pathological causes, which I have mentioned here. Just I want to skip the slides because there are so many other topics we have to discuss. Next is miqdarul bawl. As you know, this is the normal quantity of urine, 1,500 ml per 24 hours. And the normal ratio of day urine to night is 4:1. And nocturia means the excretion of urine at night when by about more than 500 ml with the specific gravity of less than 1.018. It is the characteristic feature of chronic glomerulonephritis. And we will see the causes and inferences of kasatul bawl. Like you can see in the administration of intravenous saline, diuretics, natural diuretics, such as alcohol, tea, coffee. Then inferences like the neurotic polydipsia, diabetes mellitus, diabetes insipidus, chronic renal failure in stage 1 and stage 2, and Addison's disease of adrenal cortical hormone, that is insufficiency of the adrenal gland. And qillatul bawl, that can occur because of dehydration and renal ischemia, acute renal tubular necrosis, acute glomerulonephritis, obstruction to the urinary outflow due to formation of stone. So this can cause reduce in quantity of urine. And zaram, which is anuria, so in which the quantity of urine will be 50 to 100 ml per 24 hours. That occurs in acute renal failure, chronic kidney disease in stage 3 and stage 4, then severe dehydration. And it influences renal ischemia, renal tubular necrosis, acute glomerulonephritis, obstruction to urinary outflow. And nocturia, that is very much common in chronic glomerulonephritis. And apart from that, we can see this in diabetes mellitus, tumors of prostate and bladder, anxiety, Parkinson's disease, and multiple sclerosis. Then next topic is Safa al-Kadura wal-Bawl. That is transparency and turbidity of urine. The freshly voided urine is clear and transparent with no deposits, but may be cloudy as a result of presence of phosphate and pus. And these are the physiological factors which causes turbidity in urine. After ingestion of food, urates and phosphates may produce cloudiness in the urine. Urine specimen may also develop haziness or turbidity on standing at room temperature. Then vaginal contamination in female patient is often caused by causes of turbidity in urine. Then according to Unani classics, the admixture of the following things that can produce haziness or turbidity in the urine, like mukhat or balgam, and abdominal type of protein which can be excreted through the urine. Then sadid or qi or midda, that is prudent discharge from the urine, that is called pyuria. Then chylus or chyle, which is seen in obstruction to the thoracic duct. And in case of lipuria, usually we can find bol anxiety, zubani. Then dambi mawad, like small amount of blood, and frank hematuria, in which we can see the large multiple amount of RBCs. Then rusub or khushuri, like cellular sediments in the urine. So urine may be of cloudy and sediment may be present because of presence of mucus, pus, bacteria, fungi, or because of precipitation of some of its constituents on standing. Example, amorphous phosphate in alkaline urine and urate or oxalate in acidic urine. If the turbidity has pinkish color, it is due to salt of uric acid. And urine may appear cloudy or turbid due to the presence of leukocyte and epithelial cells. Presence of mucus gives hazy appearance to the urine. And greasy cloudiness may be caused by lipiduria. And smoky urine may appear due to presence of RBCs in the urine. Next topic is qiwam al-bawl, that is density of urine, that can be correlated with the modern aspect of specific gravity. It indicates to concentrating and dilating power of the kidneys in various conditions of the body. Usually 24 hours urine specimen is preferred to determine for determination of density or specific gravity. And it is proportional to the urinary concentration of urea, sodium chloride, and phosphates mainly. And presence of albumin and sugar can also increase this specific gravity. It is generally measured by the urinometer. The specific gravity of urine is 1.010 to 1.025. This is the normal. And these are the causes which can reduce the specific gravity, like akhlat kham, incomplete maturation of matter, insufficiency of the kidney and urinary tubules, extreme cold temperamental conditions of the body, then obstruction to the urinary tubules, like anabibolia, that is due to some necrotic changes or insufficient blood supply to the renal tubules. Then excessive intake of water, insaraf tabiyat, that is deviation of body physics towards the other organ. Then excessive excretion of dilute fluid from the body. And physiological causes of low specific gravity, like high intake of fluid, administration of diuretics, natural diuretics like tea, coffee, alcohol, causes excretion of urine with low specific gravity. And pathological causes like diabetes insipidus and chronic renal diseases, like chronic kidney disease in stage and stage 2. And hypostenuria, in which the urine is constantly maintained at a specific gravity of less than 1.007. And there will be a concentration problem in the kidneys, like in condition like pyelonephritis, renal hypertension, diabetes insipidus, protein malnutrition, and salt-restricted diet. So in these conditions, you can find hypostenuria, in which the specific gravity will be less than 1.007. Then causes of high density of urine. It is because of two factors. One is excess of body humors, like the domination of body humor, which are matured and viscous, are evacuated through the urine during crisis. And defective maturation of matter, incomplete maturation of matter, is caused by accumulation of extremely viscous matter in the body. And when this extremely viscous matter, when it is expelled out through the urine, that causes high density of urine. Like in cases of Zuban, that is degenerative conditions or atrophic conditions. Then acute fevers, diabetes mellitus, then renal parenchymal diseases, then end stage of humoral fever, then rupture of abscess through the matter of abscess is evacuating out through the urine. Then acute diseases like domination or contamination of matter. So these are the causes of high density urine. According to modern science, the physiological causes like low intake of fluids, excessive sweating or dehydration. Then pathological causes like diabetes mellitus, which is causing glycosuria, and hematuria and albuminuria. All these abnormal constituents which are excreted out through the urine, that will increase the specific gravity. Then it is also increase in hyperparaxial condition, congestive heart disease, congestive heart failure, rehydration, eclampsia, acute nephritis, and all other causes which results in oliguria and lipoid nephrosis. Then excretion of urine usually of high specific gravity is called hyperstenuria, in which the specific gravity is more than 1.025. And one condition that is called isostenuria, in which the specific gravity will be fixed 1.010. That indicates poor tubular reabsorption in the kidneys, like a condition which is called ESRD, end-stage renal disease, which is the final or the consequence of CKD. And apart from that, we can see this isostenuria in ADH deficiency, arteriosclerosis of the kidney blood vessels. So in which the concentration of urine will not happen, and the specific gravity will be maintained in a specific level, that is 1.010. Then next feature is Rye-Hall ball, that is odor of urine. It has a clinical significance only in the fresh specimen of urine, and food and drug may also cause a distinct odor in urine. The odor of urine is recorded as normal, aromatic, medicated, ammoniacal, and putrid and strong smell. Mildly aromatic odor is due to presence of volatile fatty acids. Ammoniacal smell is due to bacterial action on urine when allowed to stand. Urea is decomposed to form ammonia and giving strong ammoniacal smell. So specifically, this ammoniacal smell will be very much strong in cystitis and retention of urine, and the urine will appears cloudy. Then the presence of ketone bodies in urine leads to sweet or fruity odor, or the smell of rotten apple in the urine, that is indicating diabetic ketosis or acidosis, and seen in severe uncontrolled diabetes mellitus. Then foul smelling odor, that indicates urinary tract infection, especially due to coliform infection, that is gram-negative bacteria. Then fishy odor is caused by infection with E. coli. Then this is the classification which is mentioned in Rye-Hall ball, that is odor of urine, odorless urine, acidic smell of urine, sweet smell, foul smelling urine, then putrid or rotten smell of urine. And these are the inferences. Odorless urine is seen in cold temperament, insufficient hararat gharizia, and fujaja mufarrata, that is improper maturation of morbid matter. Then acidic urine will be seen in acute disorders like extreme hot temperamental conditions, and hararat ghariba, in which the concentration and the specific gravity will also be increased along with the acidity. Then diabetes mellitus, in sweet smell will be seen in diabetes mellitus. Urine smell like fresh grass. In advanced stages, we can see the fruity or fruity smell that denotes ketonuria, or the excretion of ketone bodies through the urine in uncontrolled diabetes mellitus. And foul smelling urine is seen in acute disorders like septicemia, pyemia, and liver failure. Putrid or rotten smell is seen in hemiapnea, that is the septic fevers, gonorrhea, syphilis, and viral bananitis. So these are the infective conditions in which we can find putrid or rotten smell in the urine. And this is reaction or pH of urine. According to Kabiruddin, Allama Kabiruddin, he mentioned that some of the ancient Unani physicians mentioned that taste and tactus can be the feature of Adal al-Bol, but nowadays we can correlate the taste with the reaction of urine. So the freshly voided normal urine is usually slightly acidic, and its pH is 4.6 to 7.0. This, and the average is about 6, and it can be measured with litmus paper. And alkaline, when the urine becomes alkaline on standing due to decomposition, that is the conversion of acid phosphate into alkaline phosphate. So acidic urine can be seen in physiological conditions like high protein intake and ingestion of acidic foods, and acidification therapy, that is to treat the urinary tract infection and to prevent the precipitation of calcium carbonate and phosphates or magnesium ammonium phosphates. So this specific therapy is introduced by using the medicines which are diuretic in hard temperament, that is called Mudira Tibol Harra, that will produce acidification therapy, that will cause acidification therapy and change the pH of urine. And some pathological causes like respiratory acidosis and metabolic acidosis in uremia, like when the renal failure occurs and all the renal parameters are elevated, that can result in respiratory and metabolic acidosis. Then diabetic ketosis and starvation can also increase the pH. Then febrile illness in children and severe diarrhea, chronic nephritis, leukemia and scurvy also produces acidic urine. And urinary tract infection caused by E. coli results in acidic urine. And apart from that, other infection like pseudomonas that will cause usually the alkaline urine. And the physiological causes of alkaline urine, like diet which is high in vegetables and citrus fruits, milk and other dairy products causes alkaline urine. And postprandial urine becomes less acidic or slightly alkaline due to the excretion of acid into the stomach after eating. And alkalinization therapy to prevent the crystallization of uric acid, oxalate, and cystine. And sodium bicarbonate, potassium citrate, and acetozolamide may produce alkaline urine. And some of the pathological causes like urinary tract infection like Proteus and Pseudomonas, which will cause cystitis and other UTI infections, respiratory alkalosis, metabolic alkalosis. In all these conditions, we can find alkaline urine. Next feature is zubdatul bawl, that is foam or froth of urine. So, istidlal alwan al-zubdatul bawl, inference from the color of froth, then inference from the size of froth, then inference from the amount of froth, and inference from the disappearance of bubbles or which are found in urine. So froth is seen in diabetes and renal calculi due to abnormal constituents of urine, due to glycosuria and other abnormal constituents which are excreted out through the urine in case of renal calculi. Then urinary tract infection and infections which are triggering microorganism causes foam in the urine. Then severe dehydration due to any pathological conditions. Then large size foam which disappears quickly could be because of glycosuria. It is mentioned in the classical text. Then foam in urine due to vesicocolic fistula can be indicator of tumor in the pelvic organs like in the rectum or colon, and Crohn's disease of the ileum. If the foam are small and tiny with massive amount and stays for a longer time, over 30 minutes, which do not disappear and destruct easily, it could be suspicious of proteinuria due to renal pathology, like chronic kidney disease or acute kidney injury. Then persistent proteinuria could be a sign of kidney disease. And foam test, it is mentioned in the modern books. So yellow foam on top of the urine sample denotes the presence of bile pigments in urine. It is an indication of jaundice. Then Rusub al-Bawl, we have two types of Rusub. One is Rusub al-Mahmud and Rusub al-Ghair Mahmud. According to Unani classics, Rusub al-Mahmud usually indicates to proper maturation of food and matter in the body and the proper digestion. And Rusub al-Ghair Mahmud usually indicates to some pathological conditions. And again, the Rusub al-Ghair Mahmud is classified into various types, like the Rusub al-Khurati or Rusub al-Khushuri, Rusub al-Lahmi, Rusub al-Dasmi, Rusub al-Middi, Mukhati, Sheri, Ramli or Haswi, then Alqi al-Damvi. So among these different kinds of Rusub, our Unani Hakeems are mentioning that the Rusub which are pink in color or reddish in color that are originating from the kidneys, and the Rusub which are white in color or colorless, usually that signifies to any pathological condition in the bladder or in the lower urinary tract. And the Rusub which is seen by the naked eyes that cannot be correlated with the microscopic examination of urine, in which you can see different organized and unorganized precipitations or sedimentations. So urine microscopic examination is routinely done on centrifuge urinary sediments. The main pathological elements of urine sediment include RBCs, WBCs, cast, and less important elements like yeast, crystals, and epithelial cells. So there are two general types of urinary sediments. One is organized, which includes cast, hyaline epithelial cast, granular cast, blood cast, and waxy and mixed or pseudo cast. So all these type of casts usually not found in urine, definitely it will signify to some pathological condition in the kidneys, like chronic kidney disease or acute kidney injury, or any intoxication which is caused by some heavy metal poisoning, or any necrotic injury to the renal tubules. Apart from that, we can see the epithelial cells in the urine and leukocytes or pus cells that indicates to some chronic recurrent UTI, then erythrocytes, spermatozoa, then urethral filaments, tissue debris, fibrin, microorganisms, animal parasites, then foreign substances in the urine. And in unorganized sediments, we can see the crystals of ammonium, magnesium, phosphates, full phosphates, and calcium oxalate, calcium phosphates, calcium sulfates, then calcium carbonates, uric acid crystals, then cystine and cholesterol, hypochloric acid crystals, then leucine, tyrosine, and sulfonamide and urate crystals. So this urinary examination, microscopic examination, is routinely done in the centrifuge urinary sediments. Now I'll discuss a few topics of Unani aspect of kidney disorders. Like kidney disorders are mainly classified according to the classification of the diseases. According to Ibn Rushd, the kidneys are susceptible to get all the diseases of sui-misaj, inflammation, obstruction, ulcers, calculus, and sandy particles and injuries. So functional defects which can occur in the kidneys due to sui-misaj, in which we can see polyuria and polydipsia, which are the clinical manifestation of diabetes mellitus, as well as the zoophil, that is CKD, leading to major systemic pathological condition. Then sexual deformities can also be seen in the kidneys, like producing stone and sandy particles, inflammatory condition, emaciation, and erosions. Then tafarruq, which are producing some ulcers and wounds, abscess, tumors, cysts in the kidneys, that covers all the pathological conditions. In sui-misaj har kulia, usually the functions are disturbed, and we can find the clinical manifestations like polydipsia, polyuria. And when these functions will get disturbed for chronic and persistently, then the kidney will become weak. That is called insufficiency or zoophil. And the urine will be of sanguineous in nature. That is called bole ghosali. And patient will have specific features of chronic kidney disease. Then according to Ibn Rushd, diabetes har, that is diabetes mellitus, is kind of hot, ill temperament of kidneys and liver, which includes symptoms like polydipsia, polyphagia, polyuria, in which the quwwat jaziba is enhanced and in the kidney, and quwwat masika and quwwat mumayyiza, that is power of selective reabsorption, get insufficient in the kidneys. Therefore, the kidney is secreted immature and low density urine, that is called boletibni, that is commonly seen in diabetes mellitus. And amraz tarkib, which occurs in kidneys, like constriction or atrophic changes in the lumen of renal tubules. This subsequently causes zoophil, insufficiency of the kidneys. And we can see the clinical manifestation like increased frequency of urine, nausea and vomiting, anorexia, breathlessness, itching, and dull aching pain in the renal area, that is in lumbar region, and lack of libido. Apart from that, we can see the tahabbuj wajhi, that is facial puffiness, pedal edema, pallor, anemia, poor nutrition. And these are the obvious signs which can be found in chronic kidney disease and renal failure, chronic renal failure. Then obstruction are produced by the estetas which comes for the filtration in the urinary tubules due to akhlat ghaliza. When these akhlat are passing through the kidneys, they will form sandy particles in the kidneys, and that will obstruct and form the stone. So commonest cause of obstruction in the kidneys are formation of calculus and sandy particles, and the clinical manifestation of obstruction are of heaviness and dull aching pain in the lumbar region. Then this pain radiates anteriorly to the loin and groin and external genitalia from the side of affected kidney. Sometimes the pain is colic in nature and occurs in the. So these are the pathological condition is described in the that is breach in continuity which occurs in kidney, like discontinuity in the germ of kulia. Consequently occurs in secondary diseases like then abscess, cold abscess, renal pustules, renal tumors, and renal cysts, and renal erosions. So all these pathological conditions usually this occurs usually as a secondary effect over the kidneys, and that can also lead to some systemic disorders. So with this few slides, I will conclude my talk. Thank you very much. If you have any doubts, you can clarify, you can ask. Actually, collected these different pictures of urine color and its different shades from Hyderabad Kidney Center, where I did a project work. And these are not just a thing which is described in the classical text that can be easily do experimentation, and we can do research on that by using the modern parameters. For example, Ghulamuddin, which is commonly found in chronic liver disorders and as well as chronic kidney disease. We can collect the urine sample and we can assess the features by using a calorimeter and other features with the olfactometer and pH meter, and we can find the properties of urine, and through which we can modernize and we can correlate the features with the modern aspect. And really, this is the main work to correlate and explore our ancient classical aspect with the modern medicine. Thank you very much.
Any question from the audience? Thank you, sir, for your exceptional and thought-provoking presentation. Your ability to blend the depth of Unani wisdom with the precision of modern diagnostic has truly expanded our horizons. I kindly request Professor Ismat Shami, ma'am, HOD Ilmul Amraz and Niswa, to present a token of appreciation to Dr. Syed Azizullah Hussaini, sir, as a gesture of our respect and gratitude. Thank you, ma'am, for doing the honors. Great conversations are often brewed over a cup of tea. As we take a moment to absorb these valuable insights, let's recharge with a short tea break. We kindly request everyone to return to the hall in a half an hour as we gear up for the next session. Enjoy your refreshment as we will see you soon. Sorry, we will have only tea break for 15 minutes.
Hello, delegates. Kind attention here. There is a microscope demo which has been arranged on the left side of the auditorium. I request all of you to kindly go and take a demo on it. It's a more advanced version of the microscope. Okay, thank you.
और कब से है?
4-5 दिन से। लोकल रोजी डॉक्टर है ना, मोन्टू डॉक्टर से दवा लिए थे।
खांसी सर्दी भी है?
हाँ हाँ।
पैखाना कैसे?
Welcome back, everyone. I hope you feel refreshed and ready to dive into our second session of the day. The microscope is not just an instrument, it is a bridge to the hidden world within, unveiling the complexities of life at its most fundamental level and guiding us towards deeper understanding and innovation in medicine. We are truly privileged to have with us Dr. Ashwini B.R., Associate Professor in the Department of Pathology at Bangalore Medical College and Research Institute. A distinguished expert in her field, Dr. Ashwini will enlighten us on topic approach to endometrial biopsy, a cornerstone in pathology that plays a pivotal role in diagnosing and managing gynecological disorders. It's our great honor to introduce Dr. Ashwini B.R. She is a distinguished pathologist with a robust educational background, holding an MBBS degree and MS Ramesh from MS Ramesh Medical College and MD in Pathology from Karnataka Institute of Medical Science, Hubli. Additionally, she is a diplomate from the National Board in Pathology and has completed a fellowship in genetics diagnosing at Christian Medical College, Vellore, under the Department of Biotechnology, Government of India. With over 14 years of teaching experience in the field of pathology, Dr. Ashwini has significantly contributed to the academic and clinical advancements in histopathology, molecular pathology, and hematopathology. She has received specialized training in molecular genetic techniques, including next generation sequencing, droplet digital PCR, and immunohistochemistry, among others. Dr. Ashwini's research has gained considerable attention, especially her work on RET PTC gene translocation in thyroid carcinoma and viral immunohistochemistry in COVID-19 related deaths. She has been a presenter at major conferences, including the annual conference of the National Association of Medical Pathologists 2023. We are privileged to have Dr. Ashwini share her invaluable insights with us today. Please join me in welcoming her with a big round of applause. Please, ma'am, take on the stage.
For the wonderful introduction. At the outset, I would like to congratulate the organizing team for holding a national conference and giving me an opportunity to talk in this beautiful session. A wonderful gathering here. Am I audible at the end? No? Now? Is it better? Right. Okay. Today's topic is the approach to endometrial biopsies. Now, all the pathologies here and all the gynecologists here will agree with me that the endometrial biopsies is actually the bread and butter of the pathologists. Okay. About 25% of all our biopsies, small biopsies that we get is endometrial biopsies only. Okay. And day in, day out, we keep seeing it, but yet it does give us nightmares at times. Okay. Now, the more commonest indications for endometrial biopsies that we get is AUBs. There's an abnormal uterine bleeding. Earlier, this was called dysfunctional uterine bleeding, but now it's called abnormal uterine bleeding. It can have both structural and non-structural causes for an abnormal bleeding. Now, the Federation of Gynecologists and Obstetrics have given an acronym for this, which is called as PALM. Okay. Now, PALM is the polyps, adenomyosis, leiomyomas, malignancies, hyperplasias. All of these conditions are called as PALMs, and coins are basically something which is not seen in the endometrium. There's no structural abnormalities that we see, okay, which includes coagulopathies, ovulatory dysfunctions, endometrial causes, iatrogenic, and sometimes not identified at all. Among this, these coin lesions are very common in the reproductive age group and in the perimenopausal age group, okay? Whereas the structural causes, that is, the palm lesions, are very common in the perimenopausal and the postmenopausal age group. So when we are seeing the endometrial biopsies, the most important thing that we have to see is what is the age group that we are talking, okay? Because I have to set in my mind, what am I going to see next, all right? And then we start seeing what all will be there. Okay. Now, foremost, when the tissue comes to me, what I have to evaluate is it adequate for my reporting? All right. Now, sometimes it is adequate, sometimes it's inadequate, and sometimes it is, tissue is there, but it is unaccessible. What do I mean by this? We get sometimes only the mucinous material.
Okay, sometimes there will be ectocervical tissue, that is stratified squamous epithelium from the cervical tissue. The gynecologist might have not met the required depth to get the endometrial tissues from the body of the uterus. Okay, so in that case, it becomes very difficult to assess. It becomes an inadequate specimen. All right. Now, sometimes we do get endometrial tissue, but it might be very scant, in which case the correct report might not be possible. Now, what do I define when I say that it is adequate sampling? If I am talking about a post-menopausal age group, okay, the endometrial sample that I'll get is very little because it's already atrophic endometrium, which is there. So up to 10 strips of endometrial tissue is considered as adequate if I'm talking about a post-menopausal women. Now, if it's a perimenopausal or a premenopausal women, the 10 to 30 endometrial strips should be there for us to assess and give out a report of negativity. That means I'm not finding anything, any malignancies or any ATPs, minimum 10 to 30 tissue must be there. If it's more than 30 strips of endometrial tissue, then nothing like it. I can give with confidence that of 99% that there is no lesions that will be found if I give a negative report. Now, what do the gynecologists do if I say that it is an inadequate sampling? That depends on what is the clinical suspicion again. If they are really thinking that there's something wrong in the ultrasound, or there is a strong clinical suspicion that yes, something is really wrong in the endometrium, then we suggest that there is a rebiopsy if it's inadequate. If they are not suspecting anything on the ultrasound, suppose if it was a leiomyoma and they had given us the endometrial tissue as a completion just before doing the hysterectomy, then they don't have to redo the biopsies. Okay, they can progress themselves if I say that there is an inadequate sampling, and that will be the end of story. Okay, so before we settle into different types of endometrial lesions that I see, what we have to note here is endometrium has got two components. Okay, it has got a glandular component and it has got a stromal component. You can stop me anytime if the pace is not fine with you guys. All right. Now, when we say glandular components, no, there are these glands which will be initially very tubular in nature, small tubular glands. And these glands are lined by this columnar cells, which has got this uniform chromatin. The nucleus is very oval in their shape. And one or two mitosis I am going to see like this. Okay. Now, gradually, as the proliferation increases in the endometrium, these glands will start becoming more and more tubular in nature. They'll become more linear. Okay. Now, as that happens, and when we cut through this endometrium, okay, to assess that, we see this pseudo stratification. Pseudo is false. So we see a false stratification that is there, but they'll all be single line of columnar epithelial cells. Now, gradually what happens, these columnar cells will start secretions. The secretions will start from the basum. Okay, so this is the basal layer, which is showing the secretions. Now, all the nucleus will be pushed to the luminal side. Now, if more than 50% of the endometrial glands are showing the subnuclear vacuolization, that is when I tell you that there is the definitive sign of ovulation that has happened. Okay. Now, once this happens, the secretions will then push the nucleus back again to the basement membrane, and they will come to the top. This secretions will then be secreted into the lumen along with part of the cytoplasm itself. That is when the height of this cytoplasm will come down. The cells will now become more cuboidal or low columnar in nature, and they will have luminal secretions. By this time, the glands will become more and more linear in nature. Okay, so that is when I start seeing this sawtooth appearance or corkscrew appearance of these glands. More amount of glandular secretions, they get exhausted. Okay, so we see this appearance in the endometrium. From here onwards, it's a definitive sign that there is a secretory changes. This is what we see in the proliferative phase. Now, the second component. What was the second component? The stroma component. The stroma initially will be very compact in nature. Means to say, the cells will have very scant cytoplasm. There is this nucleus which is appearing blue in color. So the entire cell, the slide looks blue in color. Okay. And they will have this blood vessels which will have a single layer of endothelial cells, which is very flattened. This is absolutely essential to look into the blood vessels, how they are seen. So I see these tubular glands and blood vessels which are very thin walled with this single layer of endothelium. Okay, now as they come towards the secretory phase, these stromal cells will become pre-destrualized. That means they will get more and more cytoplasm. They look very plum pink in color now. And these arterioles that we see will have these pre-destrual cells surrounding them. That is called as spiral arteriole formations. Okay, so these is what we see in the endometrium. That's the proliferative phase that is seen here, which will have a compact stroma and the tubular glands. Okay, and this is the surface lining epithelium, which is there in the endometrium. And this is the secretory changes. Now, in the secretory changes, what we are seeing is long tubular glands, which is more coil-like, with the subnuclear vacuolation that is seen in more than 50% of the glands that's there. So I know that this is ovulated and now it is in the secretory phase. Okay, and the stroma will start becoming more and more edematous and more pre-destrualized like this. So there is a secretory exhaustion, and the stroma is now showing a lot of spiral arterioles like this. Okay, now the secretory phase endometrium is always fixed dates. We also get endometrial tissue not just for AUB. We get that sometimes for infertility. When we get it for infertility, we have to date the endometrium exactly what is the date. Dating of endometrium is possible only in the secretory phases because it is fixed for 14 days. Proliferative phase can be variable. So exact dating on a proliferative endometrium is not possible. We say either it's an early, mid, or late proliferative. But when I'm talking about secretory endometrium, I can really date the tissues like this. Like by about 17 days, I will see a lot of subnuclear vacuolization in more than 50% of my glands. In my 20th day, there will be presence of a lot of peak of intraluminal secretions will be maximum. And by 23rd day, you'll see a lot of spiral arteriole formations and pre-destrual changes. And by 27th day, you'll start seeing presence of lymphocytes and neutrophils in the stroma. That means it is now ready to be shed. Okay, so when that happens, then we saw what is called as menstrual endometrium, in which you will see that there is a lot of inflammatory cells. This is not inflammation. There is no, she doesn't have any infections here. This is normal. Okay, seeing a lot of neutrophils, different thrombi, which is there. All these things is normal in the menstrual endometrium. This case, the will be collapsed. Okay, there's a lot of hemorrhage that because the stroma is now breaking apart in the menstrual endometrium to be shed. Now, in which there will be presence of these hemorrhage into the stroma, and these are called the stromal blue balls or the stromal blue plebs. Are these we see in the menstrual. Now, if I get a post-menopausal women, now what do I see? I see this atrophic endometrium. The endometrial tissue will be very sparse. Some strips of endometrium will be there like this. And these, see there, they are very cuboidal in nature, very small cells. They're not nice columnar cells that we saw in the reproductive age group. Okay, they'll be flattened. Some of them will be very cystically dilated. Some secretions will be there. Okay, very sparse tissue. So this is how we see the atrophic endometrium. Now, coming to the AUB topic, that is the abnormal uterine bleeding. There we said we have both the non-structural causes and structural causes. Now, first we will see what are the non-structural causes. Most of these non-structural causes are because of hormonal pathologies. Okay, so we can have the estrogen-related bleeding, or they can be a progesterone-related bleeding. Remember, there are two hormones which are playing a very important role in the endometrium. Okay, during the proliferative phase, there is the estrogen that is getting produced from the ovary, helping it to proliferate. Once there is an ovulation that is happening, the Graafian follicle will release the ovum and convert itself into the corpus luteum, which will secrete the progesterone, in which case the secretions will start here. Okay. All right. So if this process, the entire process gets abnormal in any way, okay, that is when the AUB process starts. Sometimes I might still see a proliferative endometrium itself. Okay. Or sometimes what happens, there can be an unopposed estrogen activity. This we see in if there is a anovulatory cycle. The follicle which is there will never undergo the ovulation. The ovum is never released. Okay. So that is called an anovulatory cycle, in which there will be an unopposed estrogen activity, in which case some of these glands which were supposed to be nice tubular now becomes distorted. Okay, there can be cystically dilated glands like this. There can be presence of infoldings, outpouchings of the glands, but by and large, they will maintain the gland to stromal ratio. Now, normally, the stroma is more than increasing more than that of the stroma. That is when we call it hyperplasia. Okay, but in a disordered proliferative phase endometrium, the gland to stromal ratio is still maintained, still normal. Okay, so that is the disordered proliferative phase endometrium because of this. Now, sometimes what happens, there can be this Graafian follicle which was there, suddenly becomes atretic. That means what? It is lost. It is not undergoing ovulation. So somebody who is producing estrogen now suddenly is withdrawing the estrogens. So that is when the stroma will suddenly collapse. Now, once the stroma collapses like this, you'll see a lot of hemorrhage amidst the stroma, but the endometrial glands will still be looking like a proliferative phase. Okay, so this is called as the proliferative endometrium with the glandular and stromal breakdown. All right. So this is not a menstrual endometrium. This is still a proliferative endometrium which had a breakdown pattern because either there is this estrogen not produced and suddenly it becomes atretic, or there is a long duration of estrogens that is getting produced. There is no ovulation happening. So estrogen is going on producing. How long will it proliferate? At one fine day, it will break down. Okay. So that is when the stromal breakdown will happen. This is what we see the pattern. Why we are bothered about this pattern is when there is a stromal breakdown like this, the glands with no. Okay. Now, once they crowd up, it looks on a first look like it's a hyperplasia, but it is not hyperplasia. This is what we are bothered about here. Okay. In a hyperplasia, the stroma has to be intact. Only then I call it endometrial hyperplasia. Otherwise, there is no hyperplasia that is happening in this condition. All right. Okay. Now, the other ones are progesterone-related bleeding. That means what? There is an ovulation that has happened, and there is a corpus luteum that is produced. Okay. But there is some abnormality in the secretory endometrium. It is not showing us the normal elongated glands, coiled appearance, subnuclear vacuolations. The predestinal changes of the stroma is not seen. That is when it becomes irregular. Now, what's happening here? I might see this disordered proliferative phase endometrium, okay, was there here. Then the follicle which was there in the ovary did undergo ovulation. So then there will be progesterone that is getting produced. But here it did not have a normal proliferative phase. Okay. So that is when it will start showing this abnormal shapes. So ideally, I should have seen endometrium like this, correct? I should have seen this tortuous endometrial gland showing secretory changes. But what do I see here is this abnormal shapes of the disordered proliferative, but the glands are still showing the secretory changes here. The stroma is showing the secretory changes. There are presence of the stromal edema. I am seeing some spiral arterial formations here and there. So that is called as irregular secretory endometrium. Okay. Now, there can be irregular shedding. What's happening here? The corpus luteum is there, but there is a defect in the corpus luteum. So this is called corpus luteal phase defect. That the amount of progesterone that it is supposed to produce is not sufficient. Okay. So the endometrial curettages that we get might show us different dates of endometrium. Some places I might see secretory changes over 21 days. I might see secretory is a places which is of 14 days, 15 days. So there is a mismatch that has happened. So this is called as irregular shedding and irregular ripening. Okay. In this case, what we have seen, there is this place which is still showing a proliferative like endometrium to me. Okay. Columnar cells, nice, this long elongated nuclei is there here. Okay. In this case, here what has happened, the glands is showing already secretory pattern. There is this basally placed nuclei, lot of interluminal secretions which is there on the top. This is what? This part is showing me secretory, this part is showing me a proliferation. So there is a mismatch that has happened. So this is what we see in the irregular shedding. Now when we say hormones, it is not just the internal hormones. People do give external hormones. There's a long bleeding that is happening. She is presented for AUP for more than 6 months. Okay. Now that has to be stopped. That's a priority. Okay. So she is be put on the hormone cycle regularizers. So because the cycle has to be normalized. This might contain both estrogens and progesterones. Sometimes she's put on only progesterones. Correct. And sometimes these are used as IUDs as well. Where we use a progesterone containing IUDs for the as a treatment also sometimes. Okay. So when we say there is estrogens and progesterones both given, okay. Now, if at all there is no history that is given to me, if the estrogens is there, sometimes they do use estrogens as a hormone replacement therapy as well. In a postmenopausal woman, she's got atrophic vaginitis, there's hot flushes, or there is osteoporosis in her. Estrogens are given to her. Okay. So in which case, I might see a proliferative like endometrium or disorder or hyperplasia until unless somebody gives me the history in my history sheet that she is on hormone replacement therapy, I will not be able to make out that whether this woman is on an external estrogen hormone. Okay. But it is not so when it comes to progesterones. When the progestins are given to the patient, they show very characteristic endometrial changes. We call pill endometrium. Okay. And what do we see here is either a decidual change or there will be secretory changes like this. In a decidual change, we see that the stroma is showing a lot of pre-decidual changes. Abundant cytoplasm is there, pink appearing cytoplasm. But the blood vessels are still like proliferative. Means they are ectatic vessels lined by single layer of these flattened endothelium cells. You are not seeing any spiral arterial formation. And the glands also are not supporting for a secretory endometrium. It is only the stroma which is undergoing pre-decidualization like this. Okay. So the glands here are still either lined by cuboidal or they are lined by flattened endometrial cells. Okay. So this is called as the progesterone changes. So this will be very sure we are talking about an external hormone. So if I see a biopsy like this and showing only these pages, I sign it out as a progesterone effect endometrium. I don't call it progesterone phase endometrium. We call it progesterone effect endometrium. Possibility of external hormone-induced changes should be considered. Kindly provide us clinical details because many a time we don't get the detail that she is already on a hormone. Okay. We sign out like this. Now, sometimes if she is on the intrauterine, levogestrel, long-acting progesterones, no? That is when I see it like this, that there is a pre-decidual changes. There is some lymphocytes also that is there, but these thin-walled blood vessels are always healthy. So whenever you see an endometrial tissue, here very important, just make it a point that first you see the vessels and then you start seeing the glands in the stroma. It's absolutely essential. Okay. The blood vessels will still continue to show me a thin-walled vessel there. They will be lined by a single layer of endothelial cells. Some amount of changes will be seen in the glands. We can start seeing the secretory phases, but they will not match with the decidualization that is there in the stroma. They will be lacking somewhere like an inactive endometrium. Okay. So that is how we know that we are talking about an external hormones. Now coming to the structural changes, okay. Commonest structural changes that we see is endometritis. There will be a beautiful history. Okay. Usually there will be a history if there is an endometritis. Either we can have an acute endometritis or chronic endometritis. Acute endometritis, we generally see if there is some pregnancy associated. Okay. So either there will be an incomplete abortion that has happened, or she is continuously bleeding. That is when I start seeing the endometrial tissue with a lot of acute inflammatory cells. Or she will definitely have a history of PID with you. Okay. So that is when you start suspecting acute endometritis. Chronic endometritis is something very important for us. She'll generally present with infertility histories. Okay. Not more than AUB, she presents to you as infertility. That or they will have PID histories with you. Okay. So to make a diagnosis of chronic endometritis, you have to see these plasma cells in the stroma. It is not sufficient to see a lymphocyte. If I see only a lymphocyte, I can see lymphocyte even in my menstrual endometrium. So that is not sufficient to call it endometritis. I have to see these plasma cells. And along with this, the endometrial glands will start showing all the reactive changes. They'll show you different types of metaplasias in my latest slides. They'll start showing different changes. Any irritation in the endometrium for a long time, they will show you this type of endometrium. One more history, extremely important, is when they present with infertility, where you have to do a detailed evaluation, take a lot of time to evaluate the endometrium when they present with infertility, because these are our own two cases. Both of them had a history of infertility and we saw granulomas in them. It is not that they will have pulmonary tuberculosis or they may not present with anything, but you might see granulomas in the endometrium like this, and very commonly presents with infertility. Okay, more than AUP. So this is what we have to bear in mind. The one more common things that we see is the polyps. Okay, very common again in the perimenopausal or the postmenopausal women. I see an endometrial polyps here. So they might present, it will be easily picked up on the ultrasound. There will be a polypoidal structure which is there, okay, either a sessile or a pedunculated polyp on the ultrasound. So many a times it does come to us that there is a polyp which is there in the endometrium. Sometimes they are incidentally identified. Why I should bother about this is in the glands which are there in this endometrial polyps can have some shapes, or they might look very different when compared to the adjacent endometrium. That is why making a diagnosis of polyps are very essential. Now, what is the characteristic feature, the key feature of an endometrial polyp is, I see these sclerotic blood vessels, very thick-walled blood vessels, and the stroma will be fibrocollagenous. Normally, what we see, the stroma will have this abundant blue cytoplasm, but here I will start seeing a fibrocollagenous stroma which is there, and the sclerotic blood vessels. Now the glands sometimes might show either a proliferative or they might be showing a hyperplasia-like features. The moment I see hyperplasia in the endometrial polyp, I don't have to jump and call it that it is a hyperplastic endometrium. I have to evaluate the adjacent endometrium as well. Did that show hyperplasia? Because there might be a pseudo crowding, an abnormal crowding only in the polypoidal tissue, but that might not happen in the entire endometrium. So that is what very important. And particularly if I'm seeing a polyp in a postmenopausal women, I have to be extremely cautious because I have to see all the glands there. Many a times there can be atypia present only in the polyp. The malignancy's presence as a polyp itself, and there can be atypical cells seen only in the polypoidal tissue. So pay a lot of attention if you are seeing a polypoidal structure in a postmenopausal women. Okay. Now coming to endometrial hyperplasia. Now the term hyperplasia we use only for the glands. That means the glands have overgrown the stroma. This is what is our understanding for hyperplasia. And it is extremely important to pick up this hyperplasia because they can become a precursor lesion for malignancy. So you have to constantly either follow up this patient or do something for her. Okay, that's the clinician's call that she has to take. All right. Now earlier, the endometrial hyperplasia, according to WHO, was a 4-tier system. That means what? They gave importance both to how the glands are arranged and if there is an atypia or not. Okay. If atypia, then it is called with atypia. If without, then it is no atypia. That is the simple understanding. But when I say simple hyperplasia, either there was a gland which was tubular back-to-back arrangement or mild irregularities. When we say complex hyperplasia, we always think there was infoldings and outpouchings and abnormal shapes and sizes of the glands. But we don't use this nowadays because more than whether how is the arrangement of the glands, whether atypia is there or not is absolute essential. Okay, so pay a lot of attention only to the atypia. In 2014, WHO has given us a classification of hyperplasia with and without atypia. So I don't have to give my reports as whether it's a simple hyperplasia or complex hyperplasia. That's not mandatory at all. Okay. In fact, it's obsolete. So I don't have to do it like that. I just have to call it, it's hyperplasia with or without atypia. That's it. All right. Now this is endometrial hyperplasia without atypia. Now what we are seeing here is we are seeing a lot of glands in the stroma. Correct? All of you agree with me? Now, there's a lot of glands, too many glands. If I do 1:1 ratio, the gland ratio is definitely more than that of the stroma here. Okay. Now look at the glands. The glands have got all sorts of sizes and shapes. Correct. They are tubular in nature. Some of them are elongated in nature. Some are showing infoldings like this. Some are showing outpouchings like this. So, but by and large, if you see the nucleus, okay. Now what's about this nucleus? Some of back-to-back arrangement. Okay. Now what is back-to-back is, this is not like the secretory endometrium. Sometimes when you see long glands of the secretory endometrium, no, and they have been cut off, they look as if they are back-to-back. It's not so. When do I call it back-to-back? There is some amount of stroma that is there in between this back-to-back arrangement. Okay. So that is when I know we are not talking about one single gland. There is no organization here. There are different types of glands, but there is some stroma that is there. Okay. This is called back-to-back arrangement. But all of these cells, will have this nice columnar shaped, oval shaped nuclei, uniform chromatin, which is there, and there is no ATPR. This is absolutely essential to see whether the ATPR is there or not. Then we call it hyperplasia without ATPR. Okay. Now coming to hyperplasia with ATPR, why am I so bothered about ATPR? ATPR happens when there is a clonal abnormality. That means what? There is some mutation that has happened in this DNA now, and this precursor mutation can progress into malignancy. If you leave her alone now, someday she'll again come back to you with the carcinoma. So you have to do something about this. Seeing this ATPR is absolutely essential. Now, how do I identify that the cell is atypical here? Now, when there is an atypical cells, you see this nuclei, they are now become more round. How did we see cells without ATPR? They were more elongated nucleus, correct? Now here you are seeing a more round nucleus, and it's very pale appearing because it's a vesicular chromatin, and you are seeing some nucleoli. These black dot that is saying inside the nucleus, it's a nucleoli that is there, okay? And you see a lot of mitotic activities like this. The best way to evaluate ATPR is compare it with the adjacent normal looking gland. That's the best way, okay? If you see an adjacent gland which is having this nice columnar epithelium, uniform chromatin, look at that, look at this cell. How are they? These cells have become more rounded. Look at the nucleus, more rounded in nature. And the chromatin has all gone and clumped itself to the periphery of the nuclear membrane. Okay, the center is very empty looking. Now compared to this nucleus, it's very elongated nucleus here. This is when I know definitely I am seeing that an atypical gland. Okay, so identifying this is absolutely essential. Earlier, the WHO had given a term called as endometrial intraepithelial neoplasia, because there was an ATPR. ATPR, we said there is a mutation that has happened and it is going to progress. It might progress into malignancy. The chances are much higher there. Okay. But they wanted to pinpoint that these lesions are more like the endometrial tissue itself. So they changed the terminology to endometrioid intraepithelial neoplasia. Why are we so bothered here again? When I give a report of endometrial intraepithelial neoplasia or hyperplasia with ATPR, it is very, very difficult to differentiate it from the endometrial adenocarcinomas. If there is already an endometrial carcinoma, which is already there in her, it's absolutely difficult to differentiate in a biopsy sample. We are not talking about a hysterectomy here. I have biopsies, some curotages which are there. The only way I can, for sure shot hit that I am talking about a carcinoma is when I see a myometrial infiltration. Okay. Now, how am I possible to see myometrial infiltration in the curotages that is being given? I don't see myometrial. Okay. So the only way I can tell that whether I'm talking about only a hyperplasia or the endometrioid type of endometrial carcinoma is if there is a stromal infiltration. If the endometrial stroma gets infiltrated, then the normal blue appearing stroma which was there now becomes more fibroblastic in nature. That means what? Anything, no, when they infiltrate, there is a type of resistance that comes. Okay, so there is a desmoplastic response from the stroma that sets in. All right, so you see this fibroblastic stroma there. The glands will now start to converge together. So that becomes more confluent and you'll start seeing papillary pattern. Now look at these glands. All irregular sizes, shapes which are there. And look at this stroma. It's now becoming more pink. Correct? Now, how was the stroma that we saw long before? We saw it's more blue in color. Correct? Now, here we are seeing more pink color stroma here. That is because it's more fibroblastic in nature. And it is showing that there is a desmoplastic response here. This is the confluence. Now, what is confluence? It's more like cribriform in nature. You are seeing glands and glands. The glands are merging together. And you don't see any stroma at all in between. So this is called as the convergence of the glands, or the cribriform pattern that are there. And all of these, look at the nuclei, each one has got a different size, different shape, definite pleomorphism that I am seeing, a lot of mitotic activity here. And the fibroblastic stroma is very evident in this. I can see papillary places. Okay, now there can be papillary tufting like this. Papillary is what? There is a lining epithelium and a fibrovascular core. Okay. Now, if the papillae are very thin and elongated like this, no, long papillae like this, that is when it more favors a presence of endometrioid carcinomas. Sometimes I can see some papillary tufting, as a metaplastic change. So that is when I should not jump myself and call it a malignancy being there. I have to be very cautious about this. Okay. We do see a lot of metaplastic changes. Metaplastic changes are non-malignant lesions. That means what? Some reactive changes. This can be present either in the inflammatory conditions, or if it's a polyp that is there, or very commonly I see in malignancies. So whenever I see the endometrial tissue, I have to take into account all of these lesions. Now, these are some of the common metaplastic lesions that we see. Squamous metaplasia. Metaplastic squamous epithelium will not show keratinization. By and large, it will not show keratinization because it's very important. Sometimes I might see the squamous cell carcinoma from the cervix to proliferating itself into the endometrial tissue. They might have given to me as endometrial curettage. I might start seeing squamous cell carcinoma there. Now, how am I very sure that I'm not seeing a malignancy here and I'm seeing only a metaplastic changes? Because it's not pleomorphic, it's not showing any keratinization there, and they are occupying the glands like this. Okay. Now, if it becomes more morule, like a mulberry, like a three-dimensional ball, if it becomes, then I call it as squamous morules. Okay, this is a benign conditions. We have to be very, very aware of all these benign conditions. Ciliated cell changes. Now, normally, only the surface epithelium of the uterus will have cilia. The glands will not have any cilia. Cilia is what with fine hair-like structures, which will help them to reach the secretions out. Okay, so this is called as a cilia. If I am seeing the ciliated cell change in the glands, this happens if there is a long duration of estrogen exposure again in an anovulatory cycles. Okay, so that is when I start seeing this ciliated changes there. Sometimes, if along with this ciliated change, if I see these intercalated cells also in between, these are polygonal cells, which is called as abundant cytoplasm, that is when we use the word tubular metaplasia. This is one more example of the tubular metaplasia. I see a lot of these intercalated cells which are there. Okay. Now, eosinophil changes. Sometimes these eosinophilic changes do give us a nightmares. Okay, they do look like malignancies for us, and we spend a slow time. We ask for a recut again to see if purely we are talking about eosinophilic changes. Now, what helps us is this nucleus. The eosinophilic changes will have this round nucleus and will not have this vesicular chromatin. Will have a uniform chromatin. Otherwise, in the malignancy or in the atypia, what did we see? That all the chromatin material had got stuck itself to the periphery that I'm not seeing here. Okay, so I do not have any mitosis also. So that is when I know that this is eosinophilic changes which is there. Sometimes we see the mucinous changes. It looks like the endocervical epithelium, but it will not be. Okay, so abundant mucins can be present in the endometrium. This is something. This is a nightmare. This case did give me a nightmare. Okay, I did take a lot of time. I did a lot of tissue sampling again and again, and a lot of recuts to identify that I'm not missing out on a clear cell carcinoma here. This case, again, when there is a lot of estrogens which is happening, see this adjacent glands. There she is seeing this normal columnar epithelium, stroma is compact, but suddenly some of these glands are showing up in clear cell change. Okay, it looks very abnormal and not supposed to be there. Look at the nucleus. They are round, basally placed, abundant glycogen. Clear cytoplasm is because of the glycogen which is there. But even after seeing 100 times, I didn't see even one mitosis. So that is when I clearly passed it out as clear cell metaplasia. Okay. If I start seeing more mitosis and if I see something else, then we have to be very cautious about this. Okay. Papillary changes. Now, papillary changes, this is not like carcinoma. We said for a carcinoma, I should see papillary changes, but there it had a fibrovascular core. But here it can be only a tufting which is there. But sometimes these papillary changes do give us nightmares at times. Okay, only one focus it will be there. And we make it a point that we tell that there is papillary metaplasia. Please follow up this patient. Okay, this is how we sign out our reports, because many a times we will see it only in one focus. And second, after 1 month or 2 months, when they repeat the biopsies, it will increase in size. We have reported cases where there was only one papillary metaplasia. Somehow it was not looking good at all. We called it, we spoke to the gynecologist that they see, there is only one focus which is showing me papillary, but I'm somehow not happy with it. Okay, when the entire hysterectomy came to me, it had a in situ malignancy in it. So don't ignore this metaplastic changes all the time. They are very, very essential to set. Okay. The syncytial eosinophilic metaplasia. This is, if it's seen in the surface epithelium, not then don't bother. If you see this syncytium-like pattern, there is no cell borders which are made out, and all of these nucleus have merged together. The surface epithelium, then we don't bother. Okay. But if I am seeing this in the glandular epithelium, yes, something is wrong in there. Hobnailing looks only very ugly, isn't it? The nucleus looks very dark and looks very ugly to us. But if you actually pay attention, you will not see any mitosis. Okay, so pay attention, relax yourself and see that you're not seeing any mitosis around. And the cells have got this hobnail pattern. The nucleus, as if it's, it's going to jump itself into the nucleus. That's how it looks. Okay, so this is the hobnail changes. Now, along with the hobnail changes, if I see these pre-decidual changes or the decidual changes in the adjacent tissue, this is called periosteal reaction. Okay, this might be associated with one of the pregnancy-induced changes that we see. Okay, now this is one more condition. Either she comes to us with AUB, and I see these products of conception there, because she herself will not show she's pregnant. She's come with abnormal, prolonged bleeding, and there'll be an incomplete abortion that has happened. Or sometimes it does come to us with the products of conceptions like this. Okay, this is a chorionic villi that we have seen here, lined by the trophoblastic cells and a lot of residual changes in the stroma. Now, when we see that, it is important for me to tell what am I seeing in the products of conception. Whether I'm seeing the villi only, if I'm seeing this chorionic plate which is there, okay, if I'm seeing the fetal tissue. The moment I tell all this, if there is a fetal tissue, that means if the products have been expelled out, they have expelled out in toto. Nothing is left behind. That is what is the meaning of this. Okay, you're telling that the process is complete and nothing left out. Otherwise, you'll have a prolonged bleeding. This is what is understood. Sometimes they'll have a strong hinge that it is pregnancy, and you don't see any villi there. That means what we have to evaluate now. There could be an ectopic gestations. Okay, so this is what is the importance for this. Sometimes they do send us for H-mole, the high DTD form mole. The beta HCG levels will be abnormally high when come for the gestational age, and you start seeing this chorionic villi is now become hydropic in nature. Okay, there is no fetal blood vessels in this. It's become as if it's a bag of water. That's called as hydropic nature. This is the cytotrophoblast at bottom, and this top layer is the syncytiotrophoblast. So when we call it high DTD form. Why do we have to give this? Once it is done and we give a report, she has to be serially followed up again with serum beta HCG levels. A serial follow-up of serum beta HCG levels that it should come down. If it is persistently high, either she have a persistent H-mole or she will statin into choriocarcinoma. So that is why serum beta HCG levels are absolutely essential. This is one more of our own case. They gave us that it is could be H-mole, and there was the serum beta HCG levels were very high. And what we saw is this: I didn't see any villi at all in the patient, and we saw only this syncytiotrophoblast and cytotrophoblast. There a lot of necrosis that was seen, and we called it choriocarcinoma. Okay, this patient was then referred to Kidby from our place. Sometimes we get samples as endometrial biopsies, but we don't see endometrium. And we see these, this was actually a squamous cell carcinoma of the cervix that progressed itself. The cervix looked very normal to them. So endometrial curettage was done, but we found the squamous cell carcinoma in the endometrium. Some of the pitfalls always have to be there, which we have to be very cautious and don't overdo ourselves, is this telescoping pattern. If there is a secretory endometrium sometimes, we might see this telescoping of the nucleus. Okay, so we because of this, as if there is a gland pattern. So we should not call these things as malignancies. We have to be very cautious about these things. Okay, now when the curettage is being given to us, sometimes this is hydrogenic. Okay, when the edges of this curettage, the glands might crowd themselves. So this is not a hyperplasia. To call it hyperplasia, I have to see intact glands. Only if there is intact gland itself in between, only then I call it hyperplasia. Otherwise, this is pseudo-crowding. I should not jump on all these things. Sometimes sample comes to us only from the lower uterine segment. They might have not reached the upper uterine segment. Okay, that is when it is hormonally less responsive. The lower uterine segment will not be a representation of the entire segment on the abdomen. Okay, because the body and the fundus is very hormonally responsive, whereas the lower uterine segment will be less hormonally responsive in nature. So I'll not see a true representation of what is happening. So we say either it is an inactive proliferative or weakly proliferative endometrium, and to correlate it clinically. This is how we sign up our reports. Now, this is the consensus guidelines that has been given by the Canadian Association how to report the endometrial biopsies. First and foremost, we'll have to tell whether the polypectomy specimens which are there, or whether it's a curettage that is all being given to us, and what is the type of the endometrium phase there is, or if there is any inflammation that we are seeing, if we are seeing any products of conception. Now, what is very important here is if there is presence of these adipose tissue, or if there is the coelomic epithelium that I have seen. Why? Because if we are looking at an atrophic endometrium, okay, the endometrium is very small, or if there was an acute endometritis, endometrial or the myometrium itself has now become very flabby because of the inflammation, the chances of perforation might have been there. So this is a critical event, which I have to immediately tell my gynecologist, see, I am seeing a fat tissue there. Very rare to find lipomatous differentiation or metaplasia. If you are seeing fat, call them and tell, just look if there is any perforation that has happened in this woman. Okay, so this is absolutely essential for us to identify. All right, so I hope all of you have learned this. Let's see how much all the postgraduates and undergraduates here. I want to take it through this quiz. Tell me what it is. 46 years AUB. What is this? What do you see? Glands are looking normal? Please answer. No? Yes. What? They are abnormal shapes, isn't it? Yes. Now, how is the stroma? It's looking pink or blue? Pink, no? What did we talk about this pink stroma? Fibroblastic response. See this abnormal shapes of these glands, correct? All of them having different sizes and shapes. So, where are we? This is the endometrioid endometrial carcinoma case. Okay. Second case, 38 years. Pay a lot of attention to the age group. They have been put for a reason there. All of them are AUBs because that's how they come to us. All of them are AUBs. Okay, 38 years. AUB. How are the glands? Gland to stromal ratio is maintained? No? Stroma is more, no? It's normal, right? Isn't it? Stroma is more. That's okay. Now then what has happened to the glands? You are seeing some secretions in the lumen, correct? But is this normal secretory endometrium that you are seeing? Nice elongated glands? No, correct. So there is irregular shape of this secretory endometrium, but there are secretions inside. Okay, so what is this? This is irregular secretory endometrium. So in this stroma, there, see this predisitualization of the vessels. I told you vessels are very important to be seen. Okay, there's a predisitualization, lot of pink thing, that is the predisitualization there. Okay, so this is irregular secretory endometrium. What are this? Is only 25, huh? What with the glands? How are the glands? Elongated glands, very beautiful, correct. What has happened? Elongated. How the shape? What is the shape? Corkscrew appearance. Very good. Where do you see that? Secretory endometrium. So this is a normal secretory endometrium that we have passed. Okay, it's a 47-year-old AUB. So structural changes are very common in 47-year-old. What are these?
Yeah.
What are these? Blood vessels, right? You're seeing this sclerotic blood vessels here. And look at the stroma in this place and look at the stroma here. Any changes? Correct? You're seeing any changes in the stroma in this place and this place? Yeah. How is this place? It's looking more fibrotic in nature. Very pink, fibrous collagenous tissue is there here. So you're seeing a fibrocollagenous stroma, sclerotic blood vessels. So what's this case? Where did we see sclerotic blood vessels and fibrocollagenous stroma? Polyp. Okay. This is the case of endometrial polyp. Last case. Okay, what's this? What is all this? What is all this? Red appearing. What is this? Hemorrhage. Okay. So there's a hemorrhage here. Now what has happened to the stroma? Stroma is collapsed. Okay. This is condensation of the stroma. So that means what? There is a breaking down of the stroma that has happened and the stromal blue balls have formed. Now, is this normal menstrual endometrium? How is the gland? Columnar appearing, no? Uniform chromatin. So what is this? This is a estrogen effect endometrium with the stromal breakdown. Okay, so this is like a proliferative with the stromal breakdown. Right? Okay. Thank you very much for your patient hearing. Thanks a lot. Any doubts? Kindly do let me know.
Any questions? Thank you, ma'am, for your incredibly insightful and thought-provoking presentation. Your depth of knowledge, clarity, and engaging delivery have truly enriched our understanding of this critical topic. Now, I kindly request Professor Arish M.K. Shezwani Sir, HOD Tahafuzi wa Samaji Tip, to present a token of appreciation to Dr. Ashwini as a gesture of respect and gratitude. Thank you, sir, for doing the honors. As we move forward in the day's proceedings, let's carry the insights shared here as a guiding light in our professional journey. The digestive system is not just the center of nourishment, but the cornerstone of body's intricate harmony. To truly heal, we must move beyond the surface anatomy and embrace a holistic view, treating the patient as a complete interconnected being. With this inspiring perspective, we now commence our last brilliant session, setting the tone for the intellectually invigorating and transformative day ahead. It is my honor to introduce our distinguished speaker, Professor Siddiq M. Ahmed, HOD, Department of Pathology at Bangalore Medical College and Research Institute, who will share his expertise on the topic Approach to Inflammatory Bowel Disease. Professor Siddiq is not only a revered authority in the field, but also a mentor to countless aspiring pathologists. We are honored to introduce Professor Siddiq, a highly accomplished medical professional with an impressive 32 years of experience in the field of pathology, including 24 years as a specialist. Holding qualifications of MBBS, DNB in pathology, and MD in pathology, he has made significant contributions to the diagnosis and understanding of gastrointestinal, breast, and thyroid malignancies and their associated pathologies. So without further ado, please join me in welcoming Dr. Siddiq M. Ahmed to the podium.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. It's truly an honor to be here today at the National Unani Medical College, and I'm grateful to the organizers that they have called me here for a talk, which I was little confused about the audience. Then I thought, okay, let me do simple as Dr. Ashwini has done it. So we'll go to the journey, fascinating journey of world of inflammatory bowel disease, which is very important topic which has to be discussed, because every now and then our gut is going to shout. Every now and then the gut shouts and tells, I'm not well. We eat so much and we don't give rest to it, right? So this problem usually occurs in youngsters, teens and youth, where this problem comes, usually male as well as female. Mild predominance in the uh, male predominance, but nowadays it is happening in females also because a lot of other habits which we have cultivated. So what is this inflammatory bowel disease? It is the chronic condition where there is swelling or inflammation of the bowel, mainly the large bowel, and it constitutes two diseases. One is ulcerative colitis, and second is Crohn's disease. So I'll be taking this journey with these headings, but hopefully I should finish within 1 o'clock. But since half an hour I required to ensure that you understand at least some gist of this inflammatory bowel disease. What is this inflammatory bowel disease? I told you it's a chronic condition resulting from complex interaction between intestinal flora and the host immunity, which is genetically predisposed. Usually when there is genetic predisposition, those people who suffer from this disease, that leads to irregularity or inappropriate mucosal immune response. See, we were only thinking about the Western world. 1 in 200 individuals in the Western world, but in India also, this has overtaken. Even we are seeing every day, at least minimum 1 or 2 cases in our daily day. Out of which GI biopsies are around minimal 15 to 20. At least one biopsy will show either it is Crohn's disease or inflammatory bowel disease. This is very we sorted out. And usually this is in a family, it runs in a family, and risk for first degree relatives 4 times. Nowadays, because of the cigarette smoking, using oral contraceptives, NSAIDs, and the altered eating habits, which causes dysbiosis, the gut flora which is there, that is getting altered, and that causes inflammatory bowel disease or inflammation of the bowel. The last one, very early onset inflammatory bowel disease, which is a specific genetic disease, what we call it as monogenic diseases, that is occurring in nowadays in the younger age group, less than 6 years of age. So indeed, I told you incidence is due to the food habits. Apart from that, we have improved food storage, decreased food contamination, and changes in the food microbiome composition. See, food storage, improved food storage has decreases the contamination as well as the microbiology flora. So that causes there is dysregulation of the immune system of the gut. So when you come to the epidemiology of IBD, I told you age of onset is between 20 to 30 years and early is the teens. Most of them are Jewish background and they have moved towards the America, what we call it as Caucasian community. But in India, in Asians and Africans also it has started. So we are failed to diagnose it because we don't have the experts in diagnosing this inflammatory bowel disease. Apart from that, monozygotic twins and dizygotic twins are also affected, and infection in the first year of life. We use immediately the antibiotics for the children who are having infection, random use of antibiotics, which also causes dysbiosis, the flora microbiome which is there, that will be altered. So I told you, entire bowel is affected from the anus to the ileum, but it also affects the entire gut in case of Crohn's disease. What are the clinical features? I told very clearly that there is a shout by the bowel to go for every now and then. That is 6 to 8 discharges per day. 6 to 8 discharges per day. And there is decreased stool consistency. This stool is very soft and watery. So that's why you need to evaluate these patients. And there is abdominal pain. If there is abdominal pain with tenesmus, you think more in terms of ulcerative colitis. If there is no abdominal pain, fever and weight loss, apart from fissures and anal tract, then you have to think of Crohn's disease. There are other extra-intestinal features which usually predominantly in the Crohn's disease, like scleritis, episcleritis of the eye, gangrenosum, pyoderma. Then you have primary biliary cholangitis, arthropathies. These are some of the extra-intestinal manifestations. So we need to go for serological marker. If these symptoms are occurring, you need to go for serological marker like perinuclear anti-neutrophilic cytoplasmic antibody, which is very much important serological marker for ulcerative colitis, whereas less for Crohn's disease. Similarly, anti-Saccharomyces cerevisiae antibodies, which are very much rise in case of Crohn's disease, but not in the case of ulcerative colitis. Apart from that, there is calprotectin, stool calprotectin, which is there, that has to be analyzed. If it is rise, that means that patient is suffering from the inflammatory bowel disease, but it is not specific, but it is very sensitive. So what is the pathogenesis? I will not go into the details of the pathogenesis.
लेकिन इसके क्या असरात हो सकते हैं ये हम नहीं समझ सकते. ठीक है?
I am not going into the details of pathogenesis. Just remember there is mucosal immunity which is dysregulated, autophagy and cellular stress response by the genes. Usually the autophagy genes ATG16L1 and IRGM. Okay, these are the two genes responsible for autophagy, and they eat the debris of the cytoplasm. So hence they direct the genes, they direct the enzyme to digest.
अभी मैं आपके सामने एक अबरार काशिफ की एक नज्म है, खुदा का सवाल, आपके सामने पढ़ने जा रहा हूँ. मेरे रब की मुझ पर इनायत हुई, कहूँ भी तो कैसे इबादत हुई.
These genes, autophagy genes, 16L1 and IRGM. Okay, immunity regulated DTPS M protein, which is responsible for autophagy. If it is mutated or it is lost, then there will be inflammation which causes altered mucosal response. Apart from that, the microbes, bacteria which are changes, they have sensitivity to mucosa that causes activation of the inflammatory response. So I will not go into the details. This is just a chart which is showing what are the things: genetic susceptibility, microbial flora, immune dysregulation, and environmental factor. These are the four which are responsible for the mucosa to react in terms of inflammation. So I said Crohn's disease is a patchy lesions which you are going to see. What we call it as skip lesions, whereas ulcerative colitis, it's a continuous process. It starts from the rectum, go till the ileum, which is a continuous response. Whereas Crohn's disease, it will be skip lesion, start from the ileum. That's why it is called as regional ileitis. And there will be formation of pseudopolyps. Pseudopolyps means there will be ulcer and an elevated mucosa, which looks like a polyp. That is why it is called as pseudopolyp. Whereas in Crohn's disease, you see the cobblestone appearance. There is an edema of the mucosa and an ulcer. It looks like a cobblestone. That's why it is called as cobblestone appearance. So these are some of the differences between Crohn's disease and ulcerative colitis. I will not go into the details. What are the gross features which you are going to see? As I told you, ulcerative colitis, it is a continuous process where the inflammation is seen from the rectum to the ileum, and the mucosa is very red and granular. And there will be superficial ulcer, it's very common, but usually there is no rectal sparing. Rectal sparing usually occurs in the Crohn's disease, whereas in ulcerative colitis, there is no rectal sparing. If you see a rectal sparing in a ulcerative colitis, it is either the antibiotics are added or treated with the patient with antibiotics, or there is treatment which is done for ulcerative colitis. So this is the red granular appearance of the colon. Entire mucosa is involved, and there are polyps which are there. Inflammatory polyps. And there is a sharp demarcation between the normal mucosa and the involved mucosa, and usually this mucosa is involved and the submucosa is involved in the ulcerative colitis, whereas in Crohn's disease there is transmural inflammation. Similarly, the gross features of Crohn's disease, I told you, it's a skip lesion. Okay, there are ulcers. The ulcers are aphthous ulcers. They aggregated to form a serpiginous ulcers, which looks like a fissures. It looks like a fissure. So you have to distinguish from the ulcers of the ulcerative colitis. Apart from that, you are seeing linear ulcers. This is the mucosa, and this is wrapping of the fat. Wrapping of the fat, what we call it as creeping fat. Creeping fat, this fat, wherever there is inflammation, the mesenteric fat gets hugged to the intestine. So that is why it is called as creeping fat. There will be perforation of the mucosa here. You can see the perforation, and these things you see in the Crohn's disease. So this is about how the ulcerative colitis and Crohn's disease manifest. And when do you want to do an endoscopy? You have to do when there is a chronic diarrhea which is not stopping for more than 6 weeks. Okay, and this stool consistency of more than 4 weeks, and bloody stool. and there is persistent pain abdomen. So once you get the endoscopy, they have to do the sampling, and the sampling is done through the endoscopic fiber, which has got a camera, a needle, and a light. So wherever there is a lesion, it takes the biopsy either by snaring. It cuts and get the biopsy, and that we need to be handled properly. So handling of the biopsy is very important in case of small endoscopic biopsies. From where you have to take the biopsies? You have to take biopsies not from one area, wherever the lesion. So you have to take the lesion biopsies from every part of the bowel, large bowel, like rectum and sigmoid colon, 2 biopsies each, descending colon, transverse colon, and the ascending colon, including the ileum, 2 biopsies each. You have to take it, and serially they have to arrange. And these biopsies which you have taken, it has to be kept on the filter paper, because if it is not been kept in the filter paper, you may lose in the bottle, or there will be chances of improperly place the tissue on the block. And then it has to be sent in 10% buffered formalin. We use buoyant solution, which is a very good fixative, which gives a good intensity of color in HND sections. See how we have taken in the filter paper, and that will be kept in the capsule. This is the capsule. And once you have taken in the endoscopic biopsy, you have to see again the samples taken from the colectomies or segmentectomies. All these biopsies, we have to take it, and we have to cut from the anti-mesenteric border and see any lesions are there. Accordingly, we have to take the biopsies from the areas which are the lesion and the normal mucosa also. You may see the polyps, you may see the ulceration, you may see the fistulas when you cut and see the intestine. And from there, you need to take the biopsy, just what biopsies you have taken in the endoscopy. Similarly, you can take it, or you can take entire cut sections. So once it is biopsy is taken, it will go to the grossing area, where you are going to orient the tissue. Mucosa is oriented, and then it will be fixed for 8 to 10 hours, and processing is being done. What is processing? Processing nothing but the tissue is kept in the chemicals, and that will be dehydrated, clear, and make it hard, so that the block which is there, we make the block that contains the paraffin that holds the tissue. So holding the tissue tight is very important to get the section, serial section. And this is the process we do, and finally we prepared, stain, and sections are brought to the table of the pathologist. So this is the block which is holding the tissue. This is the paraffin block. In that you see the sections, tissues. This is from the colon we have taken, and then it will be cut into serial section in the microtome. Micro means smaller section, microns we cut, and we stain the section. This is the section which has been prepared by staining HND. These are the small endoscopic biopsies. This is how we keep it serially. 1, 2, 3, 4, 5. From the superficial to the deep, we cut and keep it like that only, because we don't require again the deeper sections to see whether what happens in the first section, the head may be seen. In the last section, we may see the tail. So we require entire head and tail and the body. For that reason, we have to cut in the serial section from the superficial to the deep. Then we need to examine the section under the microscope. What are the things we are going to see? We are going to see, before seeing the section, we need to acquire the information. What are the information you need to say? Duration of illness. What is the microbiological findings of the stool? Then endoscopic finding. They may say that there was an ulcer, or there may be a growth, So we need to know what are the changes, morphological changes in the endoscopy, radiological finding, if there is a dilated bowel or any other relevant information like antibiotic taking or bowel preparation, whatever it is, complete request form should we have to see as a format. So in the histology, I will not go into the details. Just I'll show you the photographs. This is a normal mucosa. This is the normal mucosa, colonic mucosa with the wall. This is the circular longitudinal layer. This is the circular layer. This is the submucosa. This is the muscularis mucosa. And these are the epithelium, what we call it as cryptic gland. The gap between the epithelium is what we call it as crypt. This entire thing is a crypt. So very common in the bowel, whereas in the intestine, small intestine, there will be a villi and the crypt. Okay. So we assess the villus to crypt ratio, whereas here it is more of crypts. We'll see about the crypt, how they look like. So this is how the crypts are arranged. The crypts are arranged below the, above the muscularis mucosae. This is the, what like a test tubes arranged in the test tube rack. So if they get attached, they get placed here. So you know there is no gap much. They are just placed. The tubes are whatever the crypts we call it as. They are placed on the muscularis mucosae. This is the lamina propria. This is the lamina propria. These are the glands which contains columnar epithelium and the goblet cells. Similarly, we have labeled this just to show you the lamina propria is in between the crypts. These are the mucosal glands, and this is the in between space, what we call it as lamina propria. And this entire thing is called as a crypt. And this swollen or balloon-like cells are called as goblet cells. And this is the muscularis mucosae, and this is the submucosa. Here also you can see very beautifully stained crypts placed on the muscularis mucosae, and these are the lamina propria which contains inflammatory cells. They are normally present and they'll be present above in a dense pattern. See, you can see compare here and here, the inflammatory cells are less here compared to here. So dense at the surface, whereas less at the base of the crypt, what we call it as base of the crypt. This is the cross section of the crypt. When you cut crossly, you can see like this. This is the lamina propria which contains the inflammatory cells. And these are the beautiful glands and the goblet cells. So this is about normal mucosa of the colon, and what changes you are going to see in the ulcerative colitis. What we call it as crypt distortion. The whatever the crypt we have shown, that is distorted in different forms. I am going to show you. There will be crypt branching and crypt atrophy. These are the three changes are very important to call ulcerative colitis. Apart from that, there will be crypt destruction also that I am going to show you in the photograph. So they say that if you see a distortion of the crypt, it is 57 to 100%. It is ulcerative colitis. So this is the figure showing this is the crypt which is dilated compared to other crypts, and it contains some inflammatory cells called as neutrophils. They are aggregated inside the crypt. That is called as crypt abscess. Crypt abscess. Whereas here we can see the crypt has become irregular and branched. Irregular and branched, what we call it as crypt branching. And you see here, you can see the goblet cells, right? The vacuolated goblet cells you can see here, but you don't see them here. Do you see here? So what we call it as mucin depletion. So mucin is very important in a normal crypt. If there is a mucin depletion or loss of mucin, then it is more towards the inflammatory bowel disease. So what are the features which you are going to see? First, you have to see the epithelium, how the epithelium of the colon, whether it is ulcerated, whether there is an abscess ulcer or there is erosion, you have to see. Then you have to see the whether there is presence of goblet cells or loss of goblet cells or loss of mucin. And apart from that, you have to see for panicell hyperplasia. It is, I'll show you the photograph, panicell hyperplasia and other important findings. So they say that the lamina which I have shown you earlier, it use lot of inflammatory cells, predominantly the neutrophils. If you see neutrophils, normally neutrophils are not present, only you see the lymphocytes, very rarely you see the neutrophils. If you see the neutrophils in the lamina propria, then you have to consider there is some inflammation going on. Either it may be an infective origin or it may be inflammatory bowel disease. So you have to be very careful. So if you see this neutrophil moving into the crypt, either in the epithelium or inside the crypt lumina, then you have to think more in terms of ulcerative colitis. That is 41% what we have studied. And in Crohn's disease also you can see cryptapsis, that is 19%. Similarly, this is very important. This tells you, neutrophils will tell you activity of the colon. Suppose inflammatory bowel disease is active, that is acute, then neutrophils are going to play a role. Here, basal plasmacytosis is very important. If you see basal plasmacyte, usually normally there will be 3 to 4 plasma cells will be there in the base of the crypt. If you see more than them, that means it is ulcerative colitis. Okay, activity is denoted by the neutrophil. If you see this basal plasmacytosis and presence of neutrophil, then we call it as chronic active ulcerative colitis. Whereas only if you see basal plasmacytosis or basal plasmacyte, then we call it as chronic ulcerative colitis. Chronicity is by the plasma cell, whereas presence of neutrophils is the activity. And in eosinophils, wherever there is a repair, wherever there is an inflammation and repair, eosinophils come into play, normally present in the colon. Normally present in the colon. If they are more than 60 per nth hyperfilled, that means there is no proper treatment going on. So I told you basal plasmacytes is important apart from neutrophils. So long-standing ulcerative colitis, if you want to say that it is chronic, very much chronic, panicell hyperplasia is very much, they are pink granules which are present in the base of the crypt. Normally they are present in the right side of the colon, but if you see in the left side of the colon, it tells you that there is a chronicity of the inflammation. So this is the, what we call it as early phase called as cryptitis, the neutrophils in the epithelium, in the epithelium of the crypt. If you see neutrophils in the epithelium of the crypt, it is called as cryptitis. Okay, whereas there is configuration. What is that? Mucosal configuration. This is the villi. Normally, villi is not seen in the colon. If you see a villi in the colon, like this, it is called as villous mucosal configuration. It is very much, you can say that it is a IBD, inflammatory bowel disease. Normally, it is seen in the Crohn's disease and ulcerative colitis. There are lymphoid follicles, dark cells you can see here. There are dark lymphoid cells. Normally, they are present in the ileum. If you see follicles in the colon, that means it is what we are seeing is the IBD or inflammatory bowel disease. It is more towards the Crohn's disease. Here, you can see the crypt which is dilated. There is destruction of the mucosal epithelium and crypt is dilated, and there is degeneration of the epithelium called as crypt dilatation. Crypt dilatation, which here also you can see the mucin depletion. There is no mucin at all. And this is crypt abscess with mucin, with the lining epithelium destructed. What we call it a distortion of the crypt with crypt abscess. And here you see that two glands showing mucin Here normally the mucin is here. There is no mucin at all here. See, mucin, it's not properly visualized. There is pink color mucin. We use mucicarbamide to stain this script, and there is mucin inside this, and this is the control, whereas here there is no mucin. So hence it is called as mucin depletion. If you want to confirm mucin depletion. Then here again you see cystically dilated crypt. Cystically dilated crypt in the ulcerative colitis. Again here you can see the crypt abscess with mucin depletion. And these are the blood vessels called as vascular blood vessels, thin walled blood vessels, and this is called as ectasia, vascular ectasia, thin walled blood vessels. If you see like this dilated and congested, this is also one of the finding of ulcerative colitis. I told you earlier that there is a villus configuration. Normally, the colon doesn't have villus, but if you see villus, that is called as villus configuration. This is usually seen in resolving ulcerative colitis, or what we call it as quiescent colitis. You don't see anything in acute or neutrophilic infiltrate. You just see this type of villus configuration with less number of lymphoplasmacytes. This is the biopsy which is showing polyp. Can you make out the polyp? It is a polyp and there is an ulcer. So it's a polyp, what we call it as inflammatory polyp or inflammatory pseudo polyp, and that is seen in the quiescent colitis. Here there are a lot of mucipages. When there is destruction of the crypt, the mucin is taken care by the lamina propria cells, and there are macrophages which they engulf this mucin, and they are called as muciphages that are seen in the lamina propria. Sometimes these muciphages form a granuloma. We may mistaken for either Crohn's disease or tuberculosis. And this is the muscularis mucosae which is thickened. This is also a feature of ulcerative colitis. And there are eosinophils also here, what we call it as eosinophilic cryptitis. And here the crypts are very less. You can make it out. Crypts are very less, and this is the muscularis mucosae. The distance between the crypt and the muscularis mucosae is long. That's why we call it as atrophic crypt atrophy. And here also you can see the crypt is here, the base of the crypt, and this is the muscularis mucosae, and the distance between this muscularis mucosae and the crypt is long. Then we call it as crypt atrophy. So we grade the ulcerative colitis by a Nancy index, and this grading from 4 to 0. When there is no inflammation, we call 0. When there is an ulcer, we call grade 4. Rest of the thing, depending on the neutrophilic infiltrate, we call 1, 2, and 3. So this is what I have spoken about the cellularity, and this is the crypts which has got a fibrous band. Can you make a pink fibrous band usually seen in Crohn's disease? And these are the villus configuration which is there because of the distortion of it. This is very much in Crohn's disease, and there is a granuloma here, epithelioid granuloma, which is a compact granuloma composed of 5 epithelioid cells. 1, 2, there are many epithelioid cells. It's a compact granuloma seen in the mucosa. But we say that seeing a granuloma in a mucosa, we don't call it as Crohn's disease. You have to see in the submucosa. Unless we don't see it, we cannot call it. We call it as non-specific inflammation, indefinite for IBD. Apart from that, you see the lymphoid follicles. And these are very much important in Crohn's disease. This you don't see in ulcerative colitis. And there is a fissure which contains neutrophilic debris, neutrophilic necrotic debris, and this is very much seen in case of Crohn's disease. In a case of IBD, everyone has to, if the patient is having this disease for a longer period of time, then we have to do the biopsies after 8 years. They say that between 6 and 8 years, they are going to develop dysplasia. So we need to do after 8 years biopsy from the area to see whether there is a dysplasia. You know, dysplasia is nothing but abnormal atypical cells, which has got, as said, there is a mutation, they go in for malignancy. So you need to know whether their malignancy is lesser or high grade. So looking at these cells, you need to say that whether there is a dysplasia or not. It is very much important. So this is the dysplastic glands. Can you make out? As she said, hyperchromacy of the nucleus with prominent nucleoli. See the chromatid. It's a very coarse chromatid, and the vesicular nucleus. It is like a vesicle, and the chromatid is dispersed. So this is seen in the patient with IBD. So how the report should go? Report should go with the features, descriptive features, not the diagnosis itself. You have to describe what is seen there, whether it is an active or inactive disease, whether active or inactive disease. Apart from that, we have to see for CME, cytomegalovirus infection. That is very important because these patients are taking steroids and other suppressive drugs, and they may get infected with cytomegalovirus that is seen in the epithelium or the blood vessels endothelium or in the lamina propria. So this we have done a study. We felt that what are the features to call IBD. So there are certain authors which have conducted the study, and they found out that these are many which are required to call inflammatory bowel disease. And our present study, what we have done is we have taken 14 features. We have given 8 pathologists, and they have seen the 31 features. Out of that 31 features, we felt that these 14 features are important to call IBD. So if these 14 features are not there, then we feel that it may be a non-specific inflammation like infective colitis. So some study has got only 5 or 6, and some are more than that. So depending on that, the agreement by the features, that is called as kappa agreement. And finally, we felt that these are the 14 features which has got a value, p value less than 0.01. So this is what we have conducted. 31 features we went around, and finally the agreement is 70, between 50 and 70% agreement, which are the features. Finally, we took those features which are agreed by the pathologist and took those as a significant, and we published as a paper with 14 features as a 14 features should be there to call it as inflammatory bowel disease. So these are the 14 features which are very important to call inflammatory bowel disease. So to conclude, histopathologists, what we have agreed, they have agreed between the 31 features we have agreed. But while writing a diagnosis, we wrote it as non-specific inflammation. So the features are agreeing, but the diagnosis is not agreeing. Those agreement was only 40%. That means we have so much of subjective variation of our diagnosis. And morphological features, reproducibility is only 41%. If I have seen intra-observer variation, I have seen in the morning, again if I see in the evening, and that agreement is only 41%. That means still we are subjective, we are learning. And overall agreement with ulcerative colitis and non-specific inflammation was 78%. And the correlation between endoscopy, clinical with the histopathologic finding is only 48%. That means we are not expertise in this particular colonic biopsies, where one needs to know, because every day we are seeing these biopsies with patient coming with altered bowel habits. And the age is between 20 and 40 years. This is very important. The age is very important because youngster later on goes in for, I have seen in females of pregnancy, the inflammatory bowel disease worsens, and we have lost many of the patients. Apart from that, the male to female ratio is 1.52:1, and commonest area which is the rectosigmoid junction. So what is the take-home message? Any stool frequency more than 6 to 8 discharges and the consistency, patient has to undergo for endoscopy, not to take it lightly. Then biopsy needs to be evaluated by a GI pathologist, not the general pathologist, because we may miss it. It's a systematic approach like social architecture, epithelial finding, epithelial cellular component, and lamina propria needs to be seen. Biopsy should not be interpreted standalone. That means only biopsy. Without the history, if you see a biopsy, you are going to do errors or to make a wrong diagnosis. You require to see the request as well as the discussion. Regular CPC is important. Clinico-pathological correlation with the clinician is very important to establish a final diagnosis. Then, to say whether infective or IBD, you need to do a repeat biopsy in 6 weeks. Apart from that, follow-up biopsy should be a mandatory if a patient is suffering from this disease for more than 8 years. So thank you so much. And thank you for the organizers. They have given me an opportunity to speak on this. Any questions?
Any questions? Thank you, sir, for an incredibly enlightening session and for deepening our understanding of inflammatory bowel disease. It's my honor to invite Dr. Hamuddin, HOD Department of Ilmul Amraz, to present a memento to Dr. Sadique Ahmed as a token of deep respect and appreciation. Yes, please.
The response will be very much, and we may have we may lose the patient because they may go for perforation or they may go for complication like septicemia and others. And the reason what I felt was many of the areas histopathology has to be that inflammatory bowel disease. Not one person has to see; it has to be seen by many to come to a diagnosis of IBD. And clinicians, we have to take the information from the clinician. If you don't take the information isolatedly, if you see a biopsy, we may go wrong. So we have to ask for whether there was an ulcer, whether there was a polyp, or what type of mucosa it is. On that basis only, we need to do a diagnosis.
Thank you, sir. I again request Dr. Hamuddin, sir, HOD Department of Ilmul Amraz, to do the honors. Thank you, sir. Esteemed members of the audience, we will now take a break for lunch. This is a wonderful opportunity to unwind, recharge, and network with your fellow attendees. Let's reconvene in 40 minutes as we continue the extraordinary exploration of knowledge and collaboration on time. Enjoy your meals.
ಮಾಡಿದ್ರು. Whether I'm seeing, whether I'm audible? ಸರಿ. ಓಕೆ ಸರಿ.
advances in the field of research and diagnosis. Today, we will smoothly yet surely try to serve the audience with 3 engaging scientific lectures followed by a valedictory session at the end. So, I would request our audience to sit back, relax, and lend an ear to our esteemed speakers here. Let us all, as the audience, be the DNAs of this event and the esteemed speakers be the histone proteins. And together, we must strive to wrap all the knowledge that is going to be imparted here. Without further delay, let me introduce you to our keynote speaker of this event, Dr. Kishan Prasad HL, Professor of Pathology and Coordinator of Medical Education Unit, KSH Medical Academy of Nitte, GU Mangaluru, who has warmly accepted our invitation to join us today at this event. Due to his health issues, he is unable to join us in person, but Sir has been kind enough to be present with us through Zoom. Sir, we are truly honored to have you with us today. Pathology is one such field that requires knowledge, intuition, dedication, and commitment to excellence. And such is Dr. Kishan Prasad, who has completed his MBBS from MMC Mysore, MD Pathology from JJM Medical College, Davadgiri. He also gained expertise in advanced course in medical education at CMC Vellore. His keen and particular area of interest lies in medical education, oncopathology, and urogenital pathology. Not just that, he published an astonishing number of 157 publications in national and international journals. Today, he stands as a beacon of brilliance, knowledge, and inspiration. He is surely a duly qualified person in his field and a stalwart who has built his camaraderie with his work over the years. I mean, after learning all that about him, we can all agree that he is one standalone committee on his own. With a quote, I would like to invite Dr. Kishan Prasad to provide his valuable insights on approach to bleeding disorders. Tell me, and I forget. Teach me, and I may remember. Involve me, and I learn. Audience, please give a huge round of applause for Dr. Kishan Prasad.
Thank you. I will share the screen. I think your side, you need to allow me to share the screen. Yeah. Whether it is audible, whether it is seen, screen is seen.
Yes, sir, we are able to see your screen.
You can see, sir?
Yes.
Yeah. Yeah, thank you. Thank you, Dr. Renuka, and thank you for National Institute of Unani Medicine for giving me the opportunity. I am extremely feel privileged to stand before you for this talk on approach to bleeding disorders. I hail from Mangalore. This is the college where I'm working as a professor. It is called as the KSH Medical Academy. It is interim. It is termed as Shema, and also we are part of Nitte deemed to be university. It is called as Nitte deemed to be university. This particular talk I would like to dedicate to where I have worked as 2 years during my PG days for a patient with bleeding disorders. And he's a Dr. Suresh Anagwadi. He's a truly blissful person who is heading the Indian Hemophilia Society. And most importantly, he's himself is a hemophiliac and serves many people suffering from bleeding disorders. And this is the symbol which denotes Hemophilia Society, which we need to support the patient with the bleeding disorders. With this introduction, with the dedication to this patient with the bleeding disorders, and with the over to Sir, I would like to start my talk. This is the talk I am planning for the introduction of bleeding disorders, definition of bleeding disorders, physiology of clotting, clinical manifestation, laboratory investigations, and if possible, if time permits, I would like to discuss on some individual diseases. And in the end, we'll go with what should be the clinical approach and what should be the laboratory approach any patient with the bleeding disorders. As you aware, before you go to the bleeding disorders, you should understand the normal hemostasis. Normal hemostasis is like almost a double-edged sword. It is necessary, but in excessive or it is in a deficient state, it will cause the disease. This hemostasis, it is whenever any blood vessel is injured, blood should not ooze out, it will tend to form the clot, and hence it is prevents the blood flow from blood loss from our body. But in some patients with just like the topic of today's bleeding disorders, where this phenomena of formation of this clot will not happen and patient will tend to bleed. Okay. And this bleeding disorders sometimes very trivial to very severe. Sometimes it may be a endangered life. Okay. So this is it is a double-edged sword, and you should remember. So when you would like to call any patient with hemorrhagic disorders, that is very important for you. This patient with any patient who is having the bleeding manifestation with minimal trauma or without any unexplained bleeding, then you will be labeling this patient as hemorrhagic disorders. For example, the bleeding following trauma, it will happen me and you. But in patient with the bleeding disorders, even with minor trauma, there will be profuse bleed. Okay. And in patient with a bleeding disorder, they will present you with various epistaxis, hemoptysis, or hematemesis, or such type of symptoms. So with the trivial trauma or without any proper explanation, patient will be having bleeding manifestation. You'd like to label this patient is having the hemorrhagic disorders or bleeding disorders. In normal person, how this clot will happen, and in unfortunate scene in bleeding disorders, why this is affected. Let us see. Any it is in a human body. Whenever there is some injury to the vessel, like this, you can see this blood vessel. Whenever there is an injury to the blood vessel, there will be damage to the endothelium. Look at this, damage to the endothelium. Blood will start coming out. It is a profusely patient will bleed. As a tendency of normal hemostatic mechanism, we are having some sort of initial most event. It is called as something contracting mechanism. Is called as a reflex vasoconstriction. Any blood vessel doesn't want to lose the blood from the body. It will, as a first effect, it will do what is called as a reflex vasoconstriction. Remember, the key event here is damage to the endothelium. Following this endothelial damage, following reflex vasoconstriction, so it will form what is called as primary hemostasis. What is a primary hemostasis is? It is a primary hemostasis is clot formed by platelets. Look at this, platelet has come to the side and it has aggregated and stacked together. Okay. So platelet has come to the side and it will try to form the clot. This is called as primary hemostasis. 2 points you should remember here. During this process of primary hemostasis, there will be something called as platelet adhesion. You can note down platelet adhesion. This is the platelet adhesion. 1 minute. Okay. Platelet adhesion. You can note down platelet adhesion. And there is some platelet aggregation. Platelet aggregation. What do you mean by this platelet adhesion and platelet aggregation? Platelet adhesion is mechanism where platelet will bind to the subendothelium collagen or endothelial vessel. Aggregation is, it is a stacking of the platelets. So you should understand this disease. Some certain situation bleeding will happen because defect in the platelet adhesion, or there will be defect in the platelet aggregation. Of course, any condition wherever there is a platelet as such is low, quantitatively or qualitatively, patient will be manifesting with bleeding disorders. So that point you should remember. Second, as an immediate mechanism, we are having what is called a secondary hemostasis. What I mean by this secondary hemostasis means the platelet formed or clot formed because of the platelet, it is not very stable and it needs something called as fibrin to hold the platelet together. So this phenomena is called as secondary hemostasis. Remember, secondary hemostasis will be formed only because of activation of the clotting mechanism. Remember, 2 points you should remember. Primary hemostasis is platelet-related abnormality. Secondary hemostasis is diseases related to the there is a clotting factor abnormality. The bleeding can happen because there is some defect within the primary hemostasis or defect within the secondary hemostasis. Normally in me and you, if you are healthy, so it will be without any there is a problem. So this mechanism will go smoothly and it will form the clot and it will try to minimize the blood flow. But in patient who is having the bleeding mechanism, this phenomena is lost and patient will manifest with bleeding manifestation. So this is what I was talking about. So initially, there is a damage to the endothelium, there will be vasoconstriction, there will be platelet activation, coagulation cascade, and formation of the nice tight clot. So I will be talking what is called as primary hemostasis and secondary hemostasis. What do you mean by primary hemostasis and secondary hemostasis? Primary hemostasis is either related to the blood vessel or platelet abnormality, or secondary hemostasis is related to the what is called as clotting mechanism. And also, we are having something called as anticoagulant mechanism. In me and you, we are having wherever there is unnecessary activation of the clot, we don't want to have this clot to happen. We are having something called as anti-clotting mechanism. So there are some anti-clotting mechanism, anticoagulant, they'll be called as anticoagulant. So they are called as antithrombin 3, protein C, and protein S. These are all the this anti-thrombin, clotting mechanism. It will be activated and it will try to prevent unnecessary activation of the clotting mechanism. So these are the clotting factors. You should remember here what is. So there are 13. It is a total of 12 factors, but as such, it is a numbered up to 13. And remember, there is some factor 6. There is no factor 6. It is a not named factors. And remember, all are proteins. And remember, the source of this clotting factor predominantly it is synthesized in the liver. Look at this. You can note down it is a predominantly synthesized in the liver. And there are few exceptions. One condition you should remember is factor A, which will cause hemophilia. This anti-hemophilic factor, it is also synthesized in endothelium. Endothelium, that means blood vessel. Remember this point, any disease, acquired diseases related to the platelet or acquired diseases related to the liver, patient will be having decreased clotting factors and in turn patient will be having manifestation, the bleeding manifestation. So this is the coagulation pathway, what is happening here. So there is, remember, it is already taught. So there will be intrinsic pathway and extrinsic pathway. Remember this extrinsic pathway, always it is a small pathway where there will be tissue factor, which is a factor 3 and factor 7. So 3 and 7. Remember this point, 3 and 7. Okay. So 3 and 7. And all other factors, it will be involved in either intrinsic pathway or in the common pathway. Remember this point, extrinsic pathway is a small, intrinsic pathway is a big, and it will converge at some place to form what is called as common pathway. Ultimate aim of this coagulation cascade, ultimately it has to form what is called as fibrin clot, which is necessary for a secondary hemostasis, formation of the secondary hemostasis. And this point is very important in intrinsic pathway. The starting factor is factor 12. It will be getting activated and it will forms the factor 11. And it will, in turn, it will activate factor 9. And there will be factor 8 is also involved. So remember 12, 7, 9 and 12, 11, 9 and 8 are involved in intrinsic pathway. factor 3 and factor 7 is involved in extrinsic pathway, and factor 10 onwards, it will be getting activated. Ultimately, it will be forming what is called as fibrin. So this point is very important. I will tell you this, what is the significance of this intrinsic pathway and extrinsic pathway. Suppose patient is having hemophilia. One of the common problem is, so it is, remember, this is a factor 8 deficiency. So it is, there is some defect within the intrinsic pathway. Patient will be having intrinsic pathway defect leading to defect in the clotting mechanism. So this point you should remember. And remember this point also. So whenever there is some clotting mechanism is formed, so to break this clot, so we are having something called as fibrinolytic mechanism. So this is the fibrinolytic mechanism, plasminogen and plasmin. Okay, plasminogen and plasmin. It will degrade the fibrin and it will form what is called as fibrin degradation product. So it is basically balancing between procoagulant and as well as the anticoagulant factor ultimately decide whether patient will be having the diseases of the bleeding or patient will be having the diseases related to the thrombosis. So this is a nutshell of hemostasis. Remember, in blood injury, so as a first mechanism is a blood vessel vasoconstriction. It is, imagine you can note down one pipe you are gardening with the pipe with water with as a temporary phenomena you can press it. So it is a blood vessel vasoconstriction as a temporary mechanism by which blood flow will decrease. So next is platelet aggregation. Platelet will come to the site. Platelet will come to the site. It will adhere and it will adhesion. It will adhere or it will be showing what is aggregation. And it will be forming what is called as primary hemostatic plug. Remember this point, primary hemostatic plug. And next is, it is activating what is called as coagulation cascade, leading to what is called as secondary hemostasis plug. Remember, primary hemostasis plug is not very stable. The blood is forced, it is a flowing with very force. Blood, primary hemostatic plug is not able to sustain unless it is forming what is called as a nice clot with the stable hemostatic plug with the help of the fibrin which is formed because of the coagulation cascade. So normal individual, we are having procoagulant forces, anticoagulant forces. It is in the balance, and we are not having the diseases related to the bleeding or the clotting disease. In patient with a certain, there is some imbalance between the procoagulant forces and anticoagulant forces. Procoagulant is more and anticoagulant is less. Patient will be having the bleeding manifestation. All bleeding disorders, whatever I am talking, there will be procoagulant forces are more. Okay, anticoagulant forces are less. And in patient with thrombosis, thrombosis is formation of blood clot in the uninjured vessel. What will happen? It is a contrary to the bleeding. So there will be mechanism is ulta or mechanism is altered, where there will be procoagulant forces are less, anticoagulant forces are more, leading to unnecessary clot in uninjured vessel. So this is the way to classify these bleeding disorders. So there are 4 mechanisms you should remember, based on the mechanism what we have depicted. So you should remember the bleeding disorders can be, it is because of vascular abnormalities, platelet abnormalities, clotting factor abnormalities, and one specific disease, what is called as disseminated intravascular coagulation. Okay. As I said first, vascular disease. I told you the vessel, how it plays very important disease, very important for in a bleeding manifestation. One example for this vascular abnormality is you might have heard of. It is a vessel abnormality. So it is generally in normal in me and you in a skin or wherever it is. All these vascular channels are tightly held by collagen. Any defect within the collagen synthesis. One good example you will be, many of you are aware, is called as vitamin C deficiency, called in scurvy. Okay, patient will be having bleeding manifestations. Scurvy is a very good example where there will be vascular abnormalities. So similarly, patient is having some collagen vascular diseases, or patient who is having diseases related to vasculitis, where there will be it is a meshwork of it is a blood vessel, there is some defect, and it is not tested, it is held tightly by the collagen, and by trivial trauma, patient tend to bleed. So this is a vascular abnormality. So next is the platelet abnormality. I told you platelet disorders can happen because of quantitatively decreased or qualitative decreased. So we'll be calling what is called as thrombocytopenia. Okay, thrombocytopenia. Any conditions of thrombocytopenia or any conditions of qualitative abnormality like platelet aggregation or platelet adhesion defect. So leading to what is called as platelet abnormalities. Clotting factor abnormalities. Clotting factor abnormalities like any condition where there will be factor is deficiency. Maybe acquired disease or liver diseases, vitamin K deficiency or hemophilia. Very good example. Clotting factor abnormalities. Any condition clotting factor is low, patient will be having the bleeding manifestation. Next is very peculiar disease. At least I hope some of you might have heard of this disease called as disseminated intravascular coagulation. You may be wonder the word it is having disseminated intravascular coagulation. Then why patient is having a bleeding disorders? As the name suggests, disseminated, if I split this word, disseminated means throughout the body. Intravascular means within the blood vessel. Coagulation means clot. Okay. So this is one very acquired disease and very notorious disease where there will be disseminated throughout the blood vessel, within the vessel, throughout the body, within the blood vessel, there will be clotting formation, clot formation. Because of this unnecessary activation of the clotting mechanism, there will be too much amount of clotting factors are consumed. In the left, in the end, invariably this patient will be having bleeding manifestation also. So this is one peculiar disease you should remember. They'll be having tendency for thrombosis as well as the bleeding manifestation. Okay? So hope this is very clear. The vascular disease, platelet abnormality, clotting factor abnormalities, and disseminated intravascular coagulation. Okay. So any patient with bleeding disorders, how you should approach? Always remember, you'll be having some sort of knowledge amount, or so you are having some medical knowledge. Apply whenever you have a chance the patient to see the patient and ask for the history. So very important. Asking proper history, not just going with the straight away with laboratory diagnosis. Asking for the proper history, very important. Accurate medical history and very good thorough physical examination. And if everything is aligned, then you order and interpret the appropriate laboratory test. Don't straight away jump into the it is asking for it is a certain laboratory test unless many of the it is a diagnosis of any patient who is having the bleeding disorders. It is the diagnosis is made by clinical findings only. How we can identify what are the history you should look for? So this is the history you should ask for. Age of onset of it is a hemorrhagic it is a symptoms. If there is a congenital bleeding disorders, patient who is having congenital bleeding disorders. So it is very important. The majority of the time it will be manifested in early age group. Early age group. So depends on the age group. Very rarely congenital diseases they will be manifest within the late age group. So early age group. Type of symptoms, very important. So suppose I will tell you what is the relevance of type of symptoms. Ask for family history. Invariably, they'll be giving you some history. So my father or my mother, they had some disease bleeding history. So ask for the family history. Or certain other diseases, drug history, or exposure to toxins, or in physical examination. All this investigation, it will take you and it will be giving you clue about the various patients' disease conditions. Suppose patient who is having the primary bleeding disorders. What is a primary bleeding disorders means? Any defect with the vessel or within the coagulation or within the platelet clot formation, primary hemostatic plug formation. So what are the common manifestation of these patients? So they'll be having epistaxis. What is epistaxis? It is a bleeding from nose. Bleeding from nose. Gingival, buccal, or mucosal bleed, gum bleed. Menorrhagia. So it is a menorrhagia is excessive bleeding during menstruation. So it is also one of the very important finding, especially primary hemostatic diseases. Ecchymosis, purpura, or it is a petechial hemorrhages. It is a tiny skin bleeds, which is also giving you clue. Majority of the time, it is happens because of either vessel wall deformities or within the platelet related diseases. So this is it is a clinical picture. You can note down this patient is having very tiny it is called as a petechial hemorrhage. Little larger, it is called as a purpura. And ecchymosis is still larger. It is around a bleeding manifestation is more than 1 to 2 centimeter. So size is of 1 to 2 centimeter. So petechiae, purpura or ecchymosis, all this bleeding manifestation, it is suggestive that patient is having a primary hemostatic disease. So next is patient who is having secondary hemostasis. What is the secondary hemostasis means? So clotting factors. There is some deficiency of the clotting factors. So remember, the common clinical manifestation of secondary hemostatic disease is, one of the important disease you should remember is bleeding into tissue and joint. Look at this. This is one of the case of hemophilia. Hemophilia, one of the important bleeding, it is a clotting disorder because of factor 8 deficiency. This patient will be having invariably hemophilia. So this is the bleeding manifestation. You can note down there is some compared to this. This patient is having very huge arthrosis. It is called as hemarthrosis. Or similarly, we can identify there will be hematoma formation. It is a hematoma is soft tissue like mass, tumor like mass because of the bleeding. Okay. It can occur in any region. And also delayed bleeding. Delayed bleeding means patient is underwent some surgery today. So probably patient was not had any other manifestation. Probably 1 or 2 days later, patient will be having bleeding manifestation. So this is called a secondary hemostatic. It is a features of a secondary hemostasis. Delayed bleeding. So remember, so clinical finding, it will be giving you clue what patient is suffering from. So next is you should ask for certain laboratory investigation. What are the laboratory investigation you should ask for any patient who is having the bleeding manifestation? I told you always start with the clinical manifestation, then ask for the bleeding test. Okay, bleeding test. What are the bleeding tests you are supposed to perform? So remember, again, don't ask for very specific investigation. You should go within certain systematic manner. Okay, what is the systematic manner? It is called as the screening method. Okay, screening test. So it is one of the initial tests you are supposed to perform. Then only if there is some defect within the screening test, then only you can proceed for what is called as a confirmatory test. Okay, what are the screening test means? So one of the common tests we'll be asking for is platelet count, bleeding time, clotting time, clot retraction time, prothrombin time, and activated partial thromboplastin time, thrombin time, and peripheral smear. Okay, I will repeat. As a initial investigation of choice, we should ask for this screening test. What are the screening tests? Platelet count, bleeding time, clotting time, clot retraction time, prothrombin time, and activated partial thromboplastin time, thrombin time, and peripheral smear. So let us go with one by one. So this is the platelet count. This is the platelet within the peripheral smear, how it is seen. How it is seen. You can note down, this is the nice RBCs. You can note down, this is the nice RBCs. This is one platelet. This is one platelet. This is another platelet. So it is a quite good number of platelets, around 4 to 5 platelet I am seeing. RBCs, this is the lymphocytes. And this is, if a peripheral smear is not done properly, then you may face this. Okay, this is called as pseudo thrombocytopenia. So it is called as a pseudo thrombocytopenia. Even though patient is having too much amount of the platelets, still it is depicted as low. So this is called as pseudo thrombocytopenia. Next is, in certain situation, you should ask for what is called as a megakaryocyte. Megakaryocyte, it will never come to the blood smear. Remember this point, it will never come to the peripheral smear. So it will be there within the bone marrow. In certain situation, as a part of investigation, you need to look for the megakaryocyte status. Okay. One good example is, you may be aware of this disease called as ITP, idiopathic thrombocytopenic purpura, where the platelet is low and it is getting destroyed within the circulation. And for diagnosis of megakaryocyte, it is a ITP, we need to do the bone marrow examination. You can identify numerous megakaryocytes within the bone marrow smears, bone marrow smear. Next is, you need to ask for the bleeding time. Many of you have heard of how this bleeding time. I know that this is not done properly. So many of you are aware this bleeding time you might have seen if at all, if it is done with a finger prick or earlobe prick. Okay. So if it is done properly, it is a very good test, but the recommended test is called as the prick. It is not, may not be uniform. In such cases, the value of the bleeding time, if you do the finger prick or earlobe prick, is not sufficient. So in such cases, what we can do is recommended method is called as IV's method. Okay, IV's method. So this is one of the IV's method. This is one of the recommended method for a bleeding time. So this is very good test. If it is done in proper manner, it will be giving you the idea about the status of the primary hemostasis. Okay, primary hemostasis. Normal range is 2 to 7 minutes. Any condition wherever there is a qualitative or quantitative abnormality within the platelet, so it is a bleeding time will be very high. Bleeding time is very high. So next is one more test I'll be asking for is what is called as clot retraction time. Okay, clot retraction time. What is the clot retraction time? Is I'll be allowing the blood without any anticoagulant. Okay, not the coagulant, it is a plain blood. I'm allowing it to settle like this, 1 ml or 2 ml. And if it is nicely retracted, you can note down it is this clot is formed and nicely retracted. So this is called as clot retraction time. Time taken for nice clot retraction. Okay, that is called as clot retraction time. Again, the retraction capacity depends on the platelet. Any condition wherever there is a platelet low or platelet qualitative abnormality within the platelet, this clot retraction time is low. It is very easy test, very easy test. Take 1 ml of blood from the patient in the, it is a 37 temperature, in the ideal room temperature or an ideal temperature, allow it to settle. So look for the time taken for nice retraction of the clot. So this is called as clot retraction time. Okay, clot retraction time. So far we did what is called as the primary hemostatic plug evaluation. Okay. So next is as a part of it is a secondary hemostasis. So this is one of the screening tests we'll be asking for is many of you are aware that is called as clotting time. Okay, bleeding time and clotting time. Remember, in majority of the hospital, now we are removing this clotting time because it is done in very terrible way or it is in a very bad manner. If it is not done in proper manner, this clotting time, it is a no more will be a good useful tool for a secondary hemostasis evaluation. Okay. So this is a clotting time. One of the way it can be performed is many of the center it is done is using capillary tube. Many of the lab, if you visit, what they will do is allowing the blood to settle and allowing to go into the capillary tube. And periodically, they'll be breaking and looking for any clot formation. So this is called as clotting time. Next is we are having the prothrombin time, activated partial thromboplastin time, and thrombin time. Why this point is very important? Prothrombin time, activated partial thromboplastin time, and thrombin time. There is some significance for this. Let us see what it is. I told you clotting time, if it is not done properly, it is not a no more value. Normal range is 3 to 8 minutes. Okay, 3 to 8 minutes. Any patient, if it is done in proper manner, if it is more, clotting time is more, it is telling you patient is having abnormality within the clotting factors, clotting factor deficiency, clotting factor deficiency. Next is some time I'll be taking for this prothrombin time. Prothrombin time is a very good tool, very good tool to determine, remember this point, PT, it is indicating abnormality within the extrinsic pathway and common pathway. Okay, what are the extrinsic pathway factors? So remember, there will be factor, tissue factor as well as factor 7. Or there is some common pathway. Any defect within the extrinsic pathway or any defect within the common pathway, it will be identified with what is called as prothrombin time. Prothrombin time. So remember this prothrombin time again as it is whatever it is, a modern medicine or alternative medicine. Whenever you are sending the sample for this type of test, you should send it properly. So this prothrombin time and APTT, you need to ask for specifically it needs to be sent in blue capped vacuum. Blue capped vacuum, it contains specific anticoagulant sodium citrate. Okay, so it has to be done in the sodium citrate, otherwise value is not very good. Okay, no, value is not very good. And this it is normally it is around it is 11 to 14 seconds. Remember this prothrombin time, it is in 11 to 14 seconds. Okay, and always whenever you are running the prothrombin time, you should run the control sample also. So next is partial thromboplastin time. What is a partial thromboplastin time? Partial thromboplastin time is again specific test which will be identifying intrinsic pathway and common pathway. Okay, common pathway. It will be giving you, so suppose there is some problem with the tissue factor or factor 7. Partial thromboplastin time is absolutely normal. Okay, remember this point. Extrinsic pathway, it is a PT is abnormal. Intrinsic pathway and common pathway, APTT will be abnormal. Okay, so this normal range is 25 to 35 or 40 seconds. Remember, this PT and APTT will be in seconds. Okay, it will be in seconds. And bleeding time and clotting time, it will be in minutes. Okay, it will be in minutes. So that's the importance of PT and APTT. Okay, so why this PT and APTT is done? It is most of the time it is done if it is done properly. Unlike there will be subjective, there will be where it is abnormality within the bleeding time and clotting time. If it is done with the proper manner, PT and APTT, it is a very good test to detect whether one of the screening tests for any patient who is having the bleeding manifestation. So any screening of diseases of coagulation or as a part of anticoagulant therapy, warfarin therapy, or as a part of heparin therapy monitoring. So we'll be using PT and APTT. Okay. So remember, this is will be using as a part of screening test. Okay, screening test. So what are the condition where APTT is increased? APTT is increased. It is, I told you, 25 to 35 seconds is a normal. So any patient having intrinsic pathway abnormality, when I told you hemophilia A, factor 8, okay, hemophilia B, factor 9, okay, or any patient who is having DIC, any patient who is having heparin therapy, any patient who is having vitamin K deficiency, all these condition activated partial thromboplastin time is high. So remember, this is what I was trying to say is in extrinsic pathway will be asking for PT. It is normally 11 to 14 seconds. Intrinsic pathway, it will be identified with APTT. It is around 25 to 40 seconds. So, and there is some defect within the APTT as well as PT. You should always think there is some problem with the common pathway. Okay, problem with the common pathway, and you should just go with a specific test based on the initial screening test. So next is what we'll be doing is what is called as thrombin time. Okay, thrombin time. It is not done again routinely in majority of the hospital. In very few conditions we'll be doing this thrombin time. It will be telling you about okay the fibrinogen. It is how it is in your body. Okay, fibrinogen. Okay, it is a final step of coagulation. It will be telling you about the status of the fibrinogen. Fibrinogen, how it is broken down to fibrin, if it is nicely formed or not, it will be identified with thrombin time. Again, it is not done routinely in majority of the hospital. Okay. Next is this I will skip. Okay. So next is what we'll be doing is called as platelet function analyzer. Again, this is not done routinely in the majority of the lab. In certain sophisticated lab, so they'll be doing the platelet function analyzer. Okay. What is this platelet function analyzer is? It is telling you about how the platelet is doing adhesion or aggregation. You are not looking at a quantitative abnormality. We are looking at qualitative abnormality of the platelet. Number is normal, but whether it is aggregating or whether it is a aggregate or it is a adhesion capacity or aggregation capacity is normally it is happening or not. So this test is done what is called as platelet function analyzer. It is done in certain setup. It is giving you idea about okay the how adhesion or aggregation of the platelets are happening. Okay, so this is called as this is the how the platelet aggregation defects. It will be identified with what is called as a platelet aggregation test. So this is one of the tests what is called as a Glanzmann thrombasthenia. Okay, Glanzmann thrombasthenia. So this is defect within the platelet aggregation. So you are adding certain agonist and inducing the aggregation within the it is a laboratory setup. We are using ADP, adrenaline, collagen, and ristocetin. Okay. By adding this agonist, we are noting down how is the aggregation is happening or not, and we can tell you what exactly patient is having the qualitative abnormality of the platelet. One of the common qualitative abnormality is Glanzmann thrombasthenia and Bernard-Solier syndrome and von Willebrand disease. So 3 points you should remember: Bernard-Solier syndrome and von Willebrand disease. So remember 3 points: wherever there is some defect within the qualitative abnormality of the platelets, you'll be asking for the platelet aggregation studies. Platelet aggregation study is not done routine purpose. Only in certain situation, in certain laboratory, they'll be doing this, and you need to send the sample appropriately to test for this that is a platelet aggregation studies, platelet aggregation studies. So next is, once it is done, what we'll be doing is called as mixing studies. What is mixing studies means? It is maybe little complicated, but in simple word, mixing study is what I'm doing is in patient who is having prothrombin time is abnormal and activated partial thromboplastin is abnormal. Suppose in such cases, I need to proceed with what is called as mixing studies. Okay, what does this mixing studies means? For patient's plasma, I'm adding some more plasma. Okay, some more plasma, and I'll be doing the PT and APTT again, and I'll see whether it is ratified or whether it is persisting. So this is called as mixing studies. This mixing study is commonly done with one of the first initial most is called as patient's plasma. Suppose patient is having defect within the hemophilia. Okay, patient is having abnormal APTT. What I'm taking is I'm taking patient's hemophilia plasma. I'm taking pooled plasma of any patient. I'll be adding this and I'll be testing for PT and APTT. If it is ratified, the PT and APTT which was abnormal, which is becoming normal, which is indicating likely there was some factor which was deficient in the patient's plasma, which is ratified. So it is corrected and patient is having the factor deficiency. Remember, any mixing studies with the normal plasma, if PT and APTT repeated the PT and APTT, if it is corrected, it is indicating factor deficiency. With a factor deficiency, you need to go with a specific test based on which factor you would like to assess. Okay. Suppose any chance patient plasma and normal plasma, it is not corrected. PT and APTTs are not corrected. It can happen because what is called as inhibitors. What does the inhibitor means? There will be any patient who is having one good example is hemophilia. One good example is any patient with the patient is having SLE, systemic lupus erythematosus. Okay, so there will be formation of antibodies against its clotting factors, and it will cause what is called as inhibitor. It is called as inhibitor. So there are inhibitors are basically the antibodies they are formed against certain factors. So it is any patient who is having receiving multiple transfusion or patient who is having any particular disease like systemic lupus erythematosus. In such cases, so there will be what is called as inhibitor. It will be identified if it is done with the PT and APTT is done with patient plasma, normal plasma. If it is not corrected, it is indicating inhibitor assay. So what I'm trying to say is, suppose if it is a mixing study, correctable, it is a likely deficiency of any of these factors, next you should proceed with certain test. If it is not corrected, likely patient is having inhibitor, you should ask for specific inhibitor assay. One of the good example is called as EPLA syndrome, or it's called as lupus anticoagulant syndrome. Okay, lupus anticoagulant syndrome. So that's the importance of the correction studies. So next is what I'll be doing is further testing with what is called as aged plasma and adsorbed plasma. I will not complicate further in this. Remember, this aged plasma is, I am keeping any plasma with room temperature for 48 hours. All labile plasma factors, it will degrade, and all only which is having T half is more, it will remain, is called as aged plasma. Aged plasma contains factor 7, factor 9, factor 10, factor 11, and factor 12. Okay, it is called as aged plasma. So, adsorbed plasma. Adsorbed plasma means I'm using certain substance like barium sulfate, and these factors adsorb, not absorb. Adsorb means this clotting factor, it will stick on to that. So they are called as adsorb plasma. So I'll be using this aged plasma and adsorb plasma and looking for correction studies with the PT and APTT. And I can get to know what the factor, specific factor patient is suffering from. Look at this. I'm getting to know the patient is having factor 8 deficiency. Patient is having hemophilia. That means the APTT was high, which is not corrected with the aged plasma, which is corrected with adsorbed plasma. So it is indicating patient is having a factor 8 deficiency. So similarly, suppose patient is having hemophilia B, factor 9 deficiency. I am doing aged plasma, which is corrected, and no correction with the adsorbed plasma. It is a factor 9 deficiency. So similarly, with the permutation combination, I can get to know specific the clotting factor analysis. So let us see with one by one the common condition where you can it is a initial screening test you are looking at, and it is showing this value. This is indicating prothrombin time. Patient is having bleeding. Remember this point. Patient is having the bleeding, and prothrombin time is normal. APTT is normal. Thrombin time is normal. Fibrinogen is normal. Platelet is normal. That means all screening test is normal. Still, patient is having bleeding. What can be possible like this? What can be possible reason for this? All initial screening tests are normal. Okay, all initial screening tests are normal. Prothrombin time, activated partial thromboplastin time, thrombin time, fibrinogen, platelet, all are normal. Remember, this is all the condition. Okay, any suppose patient is having very severe damage, okay, or certain diseases of the platelet function, if it is very trivial, very minimal, or vasculitis, remember this point, vasculitis, or any patient is having scurvy, okay, very patient is having scurvy, factor 13 deficiency, remember this point, factor 13 deficiency, mild factor deficiency, it may not be reflected with the initial screening test. So in the patient who is having the bleeding manifestation, all the screening tests are normal. You should think all these possibilities. Okay, all these possibilities. So next situation, I am looking at prothrombin time is high. Okay, prothrombin time is high. Activated partial thromboplastin is normal. Thrombin time is normal. Fibrinogen is normal. Platelet is normal. Okay. Only thing abnormal here is prothrombin time. Okay. As I said, prothrombin time, whenever it is high, always think of problem with extrinsic pathway. So that means ask for defect within the extrinsic pathway. Either there is some defect within the tissue factor or factor 7. Okay, factor 7. Apart from some other minor causes. Look at this, factor 7 deficiency. Okay, factor 7 deficiency. Or maybe mild deficiency of other factors. Or any patient who is having oral anticoagulant therapy, PT will be normal. Only PT will be abnormal. All other basic screening tests are abnormal. So I'll be giving you some more example. So this is condition where prothrombin time is normal. Only abnormality is activated partial thromboplastin time. Thrombin time is normal. Fibrinogen is normal. Platelet is normal. Okay, what are the possibility in this situation? Remember, whenever isolated APTT, activated partial thromboplastin time is high, always think there is some defect within the intrinsic pathway. Okay, intrinsic pathway. All the factor, whatever I have depicted, factor 8, okay, whatever it is, intrinsic factor, Okay, intrinsic factor deficiency, intrinsic coagulation pathway. Whenever there is some defect, APTT will be very high. APTT will be very high. And one more example I am giving you. In this condition, prothrombin time is long, APTT is long. All other tests are normal. TT is normal, fibrinogen is normal, platelets are normal. That means APTT and PT is normal. What are the possibility like this now? So always think there is some defect, isolated common pathway, defect within the common pathway. You can note down there is some defect within the common pathway. Okay, so there is some patient who is having the common pathway, or maybe certain deficiency of like vitamin K deficiency or liver diseases. Okay, liver diseases. Majority of the time, this situation will happen any patient who is having common pathway defect. Okay, PT and APTT will be prolonged. Okay, all other tests will be normal. Suppose the pattern is I am seeing PT is abnormal, APTT is abnormal, TT is abnormal, fibrinogen is normal or mild abnormal, platelet is normal. Platelet is normal. So this is a problem with intrinsic pathway, extrinsic pathway, and the terminal pathway. It's a terminal pathway, fibrinogen formation. Okay. So this condition will happen defect within fibrinogen. Okay, fibrinogen defect. Okay, any condition of hypofibrinogenemia, any conditions of afibrinogenemia, any condition of dysfibrinogenemia, okay, or severe liver diseases, this pattern will happen. Okay, this pattern will happen. So remember, it is just like maths. All this screening test, or bleeding diseases, just like a maths. Most of the time, it will follow the standard rule. Okay, standard rule. So next is one more situation I'm giving you. The patient is having PT is long, APTT is long, thrombin time is normal. That means fibrinogen formation or defect, not defect. Fibrinogen is normal or abnormal. Platelet is low, thrombocytopenia. Patient is having thrombocytopenia. Where this situation will happen? So this will happen. This will happen in patient who is having there is some defect with commonly one of the very common disease I told you, DIC. In common practice, we'll be seeing what is called as a DIC. DIC stand for, as I said, disseminated intravascular coagulation. Because of unnecessary clot formation, all clotting factors consumed, will be no clotting factors left to form the clot. That's why PT and APTT and platelet count, everything is abnormal. So remember, this phenomena commonly seen any patient who is having the DIC, or any patient who is having the liver disease, or patient who is having the massive blood transfusion. Next is we are having patient is having prothrombin time is normal, or APTT is normal, TT is normal, fibrinogen is normal. Only I'm getting is patient is having the bleeding. Remember that point. Patient is having the bleeding, and the platelet is low. Okay, platelet is low. What are the condition? It is a pure, nothing to do with the clotting factor. Likely there is some problem with the platelet only, or there is some predominant defect in the primary hemostatic plug. So it is a case of classical case of thrombocytopenia. We should start evaluating what are the causes of thrombocytopenia. It may be because of some nutritional deficiency, or it may be because of common viral diseases, common dengue fever, or some other evaluation, or commonly it can happen because of it is a malaria, in especially Bangalore setup. It is very important. Thrombocytopenia, very important cause for thrombocytopenia. And in rarely it can happen because of heparinase. This is again one more situation I'm giving you. PT is abnormal, APTT is it is abnormal, TT is abnormal, fibrinogen is low, and the platelet is low. Okay, so that is abnormality within all the screening tests. Okay, abnormality within all the screening tests. Where do you see this condition? What are the common condition? There is problem with intrinsic pathway, secondary hemostasis, or primary hemostasis. Commonly, very important cause, again, very important, very light side, very life-threatening condition is called as a disseminated intravascular coagulation. All these abnormal, these clotting factors are abnormal. Okay, it is called as a disseminated intravascular coagulation, common cause. Okay, common cause. So any patient with bleeding disorders, how you should approach. Okay, so straight away don't jump into the specific test. You should ask for proper clinical details and ask for commonly the initial screening test which I depicted. Okay, if based on the input from the initial screening test, then proceed for evaluation of the specific investigation. Okay. If it is based on the, without doing the straight away the initial screening test, don't straight away jump into the specific test. Okay. So any patient with a suspected bleeding disorders, ask for platelet count, bleeding time, clotting time, PT and APTT. Okay. If there is some defective platelet hemostasis, primary hemostasis, one of the important cause is platelet count is low. Evaluate for the causes of thrombocytopenia. Evaluate for the causes of thrombocytopenia. If BT is prolonged, okay, BT is prolonged, bleeding time is prolonged, and platelet count is normal. So maybe you are looking at is platelet function abnormalities, and one more important disease is called as von Willebrand disease. Okay. If there is some defect within the secondary hemostasis, abnormal PT and APTT. Okay. So if it is only PT is prolonged, so likely you are dealing with extrinsic pathway or patient is on oral anticoagulant. PT is normal and activated partial thromboplastin is prolonged. It is indicating intrinsic pathway defect. So start evaluating for intrinsic pathway defect. If there is some problem with the PT and APTT, both are prolonged, think of common pathway, or certain common disease which will affect both. Common condition is a liver disease or vitamin K deficiency. Okay. So any abnormal bleeding time, it is abnormal bleeding time, clotting time, platelet count is low. So in such cases, whenever there is it is erratic, always think of some rare disease, disseminated intravascular coagulation. So this should be the approach any patient who is having the bleeding disorder. Always, I will tell you, start with the proper clinical history, then you proceed with the specific investigation. Okay, specific investigation. So, to summarize what I have said, to conclude, bleeding disorders constitute an important class of disease. Should be managed appropriately. For that, we need to contribute for appropriate diagnosis, for early diagnosis, and clinical symptoms and laboratory investigation in systematic manner. It is a plays very important role in arriving at a specific diagnosis. And always, as I said, again, I'm reiterating, whether you are following the modern medicine or alternative medicine, always ask for the proper clinical history. Also ask for the proper screening test, then only you can ask for the specific confirmatory test. If you straight away ask for the confirmatory test, there is no use unless it has to gone in proper manner. Okay, this is what I'm trying to say. So this is the reference I'm quoting from. So various book I have taken from. I'm happy to take any other question from the audience, any of the audience. Thank you very much. Thank you, Dr. Renuka, for giving me the opportunity to speak on this. I should have been there for physically because of some urgent health issue. I am giving online lecture. Thank you very much, Dr. Renuka.
Audience, you may ask questions if any. Thank you so much, sir. You have truly embarked the event with your ingenious and expert touch, and we have really learned a lot. Now, I would request Professor Abdul Azeez Ansari, Professor of Department Tahaffuzi wa Samajite, to please present the memento to Dr. Renuka B.N., Pathologist Hospital Laboratory, on behalf of Dr. Kishan Prasad HF.
Thank you. Thank you, sir.
Thank you so much, sir, for doing the honors. Moving on, allow me to introduce you to our next highly skilled, accomplished person of immense talent, expertise, and dedication. Dr. Abid Ali Ansari, sir, Head of Department of Ilmul Amraz, NIM, Bangalore. Dr. Abid Ali Ansari, sir, is a distinguished professor of Unani medicine, boasting an illustrious career spanning over 2 decades. With a robust academic background, including DMLT, BMS, and MD, Kulliyat wa Ilmul Amraz from Aligarh Muslim University. Dr. Ansari's research endeavors have been pivotal in validating Unani concepts, etiopathogenesis, and symptomatology of diseases. His contributions to the field are evident through over 30 research papers published in esteemed journals, numerous presentations at national and international conferences, chapters published in 16 books, including Functional Foods and Nutraceuticals by Springer. He has been a vital part of several conferences, webinars, and seminars. As a testament to his academic excellence, he has taught at prestigious institutions, including NIM Bangalore and Aligarh Muslim University, where he has been awarded with Best PG Teacher Award 2009, Best Senior Teaching Faculty 2019, and yet many more that I can barely mention in such limited times. Today, he stands as an epitome of knowledge and wisdom. His substantial contributions to the field of Ilmul Amraz have left an indelible mark, enlightening and inspiring countless individuals. I won't be wrong if I say he's at the pinnacle of his academic excellence, and yet we can't envisage the progress of our department and NIM itself without his presence. Today, he'll be sharing his insight on the captivating journey of uroscopy from early practices to modern microscopic approaches. Ladies and gentlemen, join me in welcoming the exceptional educator, Dr. Abid Ali Ansari, sir, on the dais.
Assalamu alaikum warahmatullahi wabarakatuh. Respected faculties, participant, Assalamu alaikum. अब मुझे सबसे बाद में शायद इसके बाद भी अपने घर के एक लेक्चर और है, लेकिन हमारे ख्याल से बहुत कम वक्त है। चीफ गेस्ट आते ही होंगे थोड़ी देर में। मैं आपको, हालांकि इस उन्वान का जो मतलब है वो शहर अंगेज सफर है, लेकिन शायद सफर शहर अंगेज हो, लेकिन मेरी बातें बहुत मुख्तसर होंगी, इसलिए कि हमें इसी वक्त में अपने एक और कुलीग के साथ इसको शेयर करना है। हमारा जो उन्वान है वो यूरोस्कोपी है। आपने सुना होगा हुक्मा हजरात जो हैं वो कारूरे को देखकर ये बताते थे कि वो कौन से मर्ज में मुब्तला हैं। तो यहाँ बड़ा मसला है कि कारूरा कहते किसको हैं। शुरुआत में ये होता कि कारूरा जो बर्तन होता था यूरिन रखने के लिए उसे कहते थे, लेकिन अब ये चीज बदल गई है। अब कारूरा जो है वो बॉल को कहा जाता है जिसका जांच करना हो। एग्जामिनिंग ए patient's urine visually or for indication of illness including blood or pus is known as the uroscopy. Uroscopy is, जैसे आपको नाम से मालूम होगा, यूरो मीन्स यूरिन, स्कोपी माने देखना, उसकी जांच करना। The Greek word orn, which means urine, and scopio, which means to examine, inspect or contemplate. ये आपको एक दौर है जो सुमेरियन और बेबीलोनियन से शुरू होता है और आज तक का सफर कराएगा। हम इसी के तहत आपसे थोड़ी बहुत बातें करेंगे कि यूरोस्कोपी कब शुरू हुआ, कब अपने उरूज पे था और कहाँ का जवाल शुरू हुआ, और कब हम इस नए जदीद दौर के जो तरीके हैं जांच के वहां से शुरू हुआ। ये तकरीबन 4000 BC से इसका शुरुआत हुई और इसमें यूरोस्कोपी इन्वॉल्व ऑब्जर्विंग द कलर कंसिस्टेंसी, क्वांटिटी, ट्रांसपेरेंसी, ऑर्डर एंड प्रेजेंस ऑफ फोर्थ इन यूरिन। ये तमाम चीजें जो आपने पढ़ा है किताब में कि एक बाउल के अंदर क्या क्या चीजें हैं वो होती थी, उनको देखने के लिए ये उसका इस्तेमाल करते थे। द फर्स्ट टू प्रैक्टिस यूरोस्कोपी जो है, सबसे पहले बेबीलोनियन एंड सुमेरियन जो हकीम थे या फिजिशियन थे, उन्होंने तकरीबन 4000 BC में शुरू किया। और ये जो रिकॉर्ड करते थे, जो लिखते थे, वो क्ले टैबलेट्स होते थे, बर्तन जिसके बनते हैं उन प्लेट के ऊपर इसको लिखते थे। और इनके तक यूरिन के जो डिफरेंट टाइप्स थे उनके अपने लैंग्वेज में वो सिनाटू पिजू, ये वाइट या प्योर यूरिन के लिए इस्तेमाल करते थे, जल्मी फॉर डार्क और ब्लैक यूरिन, एंड बर्सी फॉर वेरी ब्राइट रेड यूरिन। They also use symbols for the worm of the urine and knot of threads, which may indicate that they notice the presence of albumin in urine. They recognize that urine characteristics change with different diseases. उसके बाद एंशियंट इजिप्ट का जमाना आता है जो कि 4300 से लेकर 332 BC है। One of the first civilizations, Sumer, knew the different diseases could change the properties of urine. Extended references to the urine examination can also be found in the ancient Egypt. In the papyrus of Kahun, 1900 BC. In ancient Egypt, about 1000 BC, described in the literature, Egyptian priests were performing the most primitive procedure to confirm pregnancy and to identify the sex of a fetus as well. For the test, priest poured the urine over the mixed cereal seeds. If germination occurred, then the test was considered positive. Yet only by nothing the actual type of seed that germinated, it was possible to predict the sex of the fetus. उसके बाद से बुकरात का जमाना आता है, क्लासिकल ग्रीस का, जो 480 से लेकर 323 BC तक का है। इसमें बुकरात का है। Centuries back in the 4th century BC, Hippocrates proved that urine was a filtrate of 4 body humors that was received through the kidneys. Also, the doctrine of the 4 humors was given by the Hippocrates for the first time. According to this theory, blood, yadam, phleg, balgam, yellow bile, safra, and black bile, soda are 4 humors. Each of them was supposed to come from a distinct part of the body, thereby embodying the pathology of a corresponding part of the body. Therefore, it was a physician's job to keep the 4 humors in balance, as any disturbance could result in diseases. इनका मानना था कि खलात के अंदर जो खराबी पैदा होती है उसके नतीजे में मर्ज हुआ करता है और इसका असर बाउल पर पड़ता है। जालिनूस ने ये बात बताई जो कि सक्सेसर था हिपोक्रेट का कि according to the Galen, the kidney enticed humus and also helped in the removing superfluous or rudderless humors. Thus, urine was a diagnostic mirror of humoral imbalance. Moreover, marvelously, it was the most widely accepted explanation of disease etiology until the 16th century. Most of the contemporary tools for urine analysis are based on almost similar concept. So there is no place for non-scientific, foolish, or the ignorant modalities in this approach. उसके बाद अरब तिब्बा का आता है जिसमें कि अबू अल हसन अब्दुल्ला बिन इब्न सीना, मोहम्मद ज़करिया राजी और इस्माइल जौजानी हैं जिनका अलग अलग जिक्र आएगा। अबू बकर मोहम्मद इब्न जकरिया राजी जो है, इनका दौर 865 से लेकर 925 एडी तक है। इन्होंने स्कोपी के साथ साइंटिफिक मेथड एलांगस टू व्हाट is customary is the 21st century, bearing the visualization of the different cells, crystals, and microorganisms as they did not have access to microscopes. Rhazes recognized hematuria as the symptoms of bladder disease and designed a number of surgical instruments, including the catheter. Catheter का जो इजाद है वो जकरिया राजी ने किया। Besides all these circumstances, they were looking at urine not only to detect the diagnosed renal disorders, but they were also judging the function of other organs and their relationships to the urine quality. These findings and diagnoses were essentially based on physical examination of the urine, and further they had to rely on their senses and experiences. They used the term karura, a part basis for the collection of urine, in their writing. However, in the later period, karura term was used for the sample of urine. Karura is an Arabic word that means flask. In a sample of urine, the Unani scholars witnessed these features: Lavanabol, Qiwam, Safaya wa Qudurat, Miqdar, Rusuk, Kaf ya Jhag, Bu ya order. One more feature is Maza test was added by the Razi. Razi ने इसमें एक और नंबर का बढ़ाया जो कि मजा है या टेस्ट था। इसके बाद इब्न सीना का दौर आता है। Ibn Sina mentioned the canon of medicine, a famous encyclopedia that as the urine spectators are quantity of consumed food and drink. Therefore, it is a sign of good and bad digestion, and also urine is an authentic shepherd for the data of the elements. In the Middle Ages, it was assumed by the scholars that almost every disease may perhaps be identified by urine examination. Moreover, there are several guidelines for the collection and examination of the urine given by Unani scholars. इसके बाद इस्माइल जुजानी का दौर आता है। इन्होंने ये कहा कि जो कारूरा है या जो पॉट बनाया गया यूरिन का, वो जो है ब्लेडर के शेप का होना चाहिए। हाँ, उसके बाद से दौर आता है कास्टाइन कास्टेटाइन अफ्रीकनस का है। ये ट्रांसलेट द वर्क ऑफ हिपोक्रेट, इन्होंने हिपोक्रेट, गैलेन और थियोफिलस और सेवरल फिजिशियंस का जो किताबें थी, जो वर्क था, उनको ट्रांसलेट किया, thus making previous teaching available to a wide audience. Later on, this work was compiled into the medical canon Articella, Little Art के नाम से जाना गया। उसके बाद से बाइजेंटाइन एरिया है, जो बाइजेंटाइन थी, बाइजेंटीन थे, उनके इलाके में उनके जमाने में, जिसमें कि थियोफिलस प्रोस्पेथरस था, he conducted a urine experiment by the heating a urine sample. Ensuing this, he revealed that proteinuria would manifest as a cloudiness as a result of the heat precipitating proteins. In addition, Byzantine uroscopists have an advanced examination of the urine segmented by the stratification. This led to the change of the medulla's bulbous shape into the more complex vessels corresponding to the shape of the body. Likewise, यहाँ मेटुला से बता रहे हैं, मेटुला इस जमाने में जो था, हम जिसको हम कारूरा कहते थे, उस वक्त ये बाजेंटीने जो है उसको मेटुला के नाम से जानते थे और उसको मेटुला ही कहते थे। उस पार्ट में वो पार्ट था जो कि सैंपल को रखा जाता था। Medulla flask is uroscopy flask, also known as the medulla, is a piece of transparent glass. This is imperative as coloration along with any deformation in the glass may lead to the misdiagnosis. That is a circular at the bottom, while there is a thin neck at the top and an opening for the patient to the urinate it. इसके बाद जो है वो जॉन्स डी कैथम्स का दौर आता है 15वीं सेंचुरी में, और thereupon endoscopy become popular and widespread so much so that is what the practiced in the home. De Catton's self-diagnostic color wheel allows people to diagnose their conditions by themselves. As a result, some patients have abandoned physicians in the favor of this at-home diagnostics gadget. The self-diagnostic color wheel was comprised of matula, which was surrounded by a big circular urine color wheel filled with 20 different color urine for diagnosis the color and consistency of the urine sample where the match the matula's color. इस आदमी ने, जो इसका जिक्र अभी हुआ है, इन्होंने एक व्हील बनाया है जिसे जिसे हम यूरियोस्कोपी व्हील कहते हैं। उस जमाने में इतना ये एडवांस थे कि जैसे आप स्ट्रिप देखते हैं, आप अगर ब्लड का सैंपल लेते हैं या कोई मेडिकल जाते हैं, आपके आपके शीशे के ऊपर कलर बने हुए हैं अलग अलग, लेकिन इस जमाने में तो बहुत 2-4 कलर देख के ही आप कर लेते हैं, लेकिन उस जमाने में तकरीबन 20 जो है वो मैथुला का बना होता था। जिस कलर का होता था उस कलर से ये बताया जाता था कि इसको कौन सी बीमारी है, इस मरीज किसका मर्ज किस जिस्म का कौन सा ऑर्गन जो है इससे अफेक्टेड है। 7वीं सेंचुरी बड़ा खराब रहा एंडोस्कोपी के तौर से। इसमें लोग लूट खसूट मचाने लगे और हर आदमी जो है फॉर्चून किस्मत बताने लगा कि हम आपको बताएंगे कि अब क्या होने वाला है, क्या नहीं होने वाला है, या किस मर्ज से कर दें और आप क्या करेंगे इसके नतीजे में ये आपका मर्ज ठीक हो गया। तो ये दौर जो है बहुत खराब रहा एंडोस्कोपी के ताल्लुक से। इसमें फॉर्चून टेलिंग या झूठी कहानियां या अपने को बढ़ा चढ़ाकर बयान करने वाले बहुत ज्यादा थे। उसके बाद से 20वीं सेंचुरी आ रहा है, इसमें टेस्ट स्ट्रिप भी हो गए। वक्त की बहुत किल्लत है, शायद हमारे गेस्ट आने वाले हैं या आ गए हैं, जो भी हो, तो मैं जल्दी जल्दी अब कर रहा हूँ। अभी एक लेक्चर और है मैडम का, उनका हक नहीं मारूंगा मैं, उनको भी कुछ कहना है। इसके बाद से जो अब जो है एट प्रेजेंट है उसमें क्या है, द टर्म नेफ्रोलॉजी हैज इन्वॉल्व आफ्टर थाउजेंड ऑफ ईयर्स ऑफ राइजिंग द
Continue to learn from one another, adapt to the new challenges, and embrace the opportunities that lie ahead. I'm confident that we will continue to make significant strides in a fight against the diseases and in improving the lives of our patients. Let us leave this inspired, empowered, and ready to face next chapter of pathology with enthusiasm and determination. Thank you all once again for your participation. I look forward to the continuous collaboration and success in the years to come. Safe travels until we meet for the next event. Thank you all.
Thank you so much, madam, for your valuable words. Allow me to introduce you to our chief guest of this evening, Mr. Chandra Shekhar. He is an experienced and dedicated government official with years of service in government sector of rural development and Panchayat Raj, Karnataka. He is 2004 batch gazetted officer through KPSC. He is selected as a section officer DPAR. He worked as an undersecretary in cooperation department and DPAR. His role as Deputy Secretary Medical Education Department has led to the implementation of NEE successfully. He even worked as Private Secretary to Minister and as an Additional Secretary in Education Department, where he collaborated closely with legal teams to ensure compliance with regulation. Currently, he is Special Secretary to Rural Development and Panchayat Raj Department, where he is committed to innovative decisions making and transparent governance and fostering community engagements. I would now humbly request our distinguished chief guest, Mr. Chandra Shekhar, to do us the honor by addressing the audience of this evening. Please, sir.
Good evening, ladies and gentlemen, and I thank for this opportunity. Yes. Sorry, sir. Yeah. I thank all the candidates on this dais, Professor Abid Ali Ansari, Organizing Chairperson, and Dr. Renuka B.N, Organizing Secretary of this institute, and Dr. Sadique Ali, Organizing Secretary, and also Professor Ghulamuddin Sofi, Incharge Director, UNI, and Dr. Abdul Azeez, Dr. Azizur Rahman, and Tasfiya Hakeem. It is indeed a great honor and privilege for me to stand before you as the chief guest of this prestigious National Conference on Pathology. First and foremost, I would like to extend my great heartfelt gratitude to the organizing to the organizers of inviting me and giving me this opportunity to be part of this remarkable gathering of brilliant minds and who are dedicated to the advancement of pathology. Conferences like this are not just celebration of achievements, but a platform to exchange knowledge, share innovations, and ignite collaborations. I am inspired by the tireless efforts of all of you here, contributing to advancements that make difference in patient care, even in diagnostic and research. And also, your work underpins the very foundation of medicine. I want to particularly thank the organizing committee, to all the speakers, panelists, and participants for their meticulous planning and execution of this event. Such conferences are no small feat to organize, and your efforts are commendable. From diverse backgrounds under one roof to further the cause of science and healthcare. Let us use this opportunity to learn from each other and grow together and continue to advance our shared mission of excellence in pathology. So I thank you once again for this honor, and I wish great success and fortune to the postgraduate scholars and also National Institute of Indian Medicine, Bangalore. Thank you very much.
Thank you so much, sir. I would now request our Director in Charge, Professor Ghulamuddin Sofi, sir, to please present memento to our Chief Guest, Mr. Chandra Shekhar, as a token of heartfelt gratitude from us. Thank you so much, sir. I would now request Mr. Chandra Shekhar to please present the memento to Professor Ghulamuddin Sofi, Director in Charge and Chief Patron of this conference. Thank you so much, sir. Next, I would request Mr. Chandra Shekhar to please present the memento to Professor Abid Ali Ansari, Organizing Chairperson in HOD Department of Ilmul Amraz. Next to Dr. Sadique Ali, Organizing Secretary of this conference. Next to Dr. Renuka B.N, Organizing Secretary of this conference too. Next to Dr. Abdul Azeez, Coordinator of this conference. I would request audience to please give a huge round of applause because everyone has put a lot of efforts in making this event a successful one. Please guys, cheer up. Next to Dr. Azizur Rahman, sir, Coordinator of this conference. Next to Professor Dr. Tasfiya Hakeem Ansari, Coordinator of this conference. Next to all our helping hands, Mr. Rafi, System Administrator. Mr. Salim, Electrician. Mr. Hanumanta, Attendant. And Mr. Mutahir, Attendant. Mr. Salim, please come up on stage. Coming? Okay. Thank you so much, sir, for doing the honors. Thank you so much, teachers. Now I would request Dr. Tasfiya Hakeem Ansari, Assistant Professor, Department of Ilmul Amraz, to please present the vote of thanks. Assalamu alaikum and a very good evening to all of you. I feel honored and privileged to propose the vote of thanks on behalf of the organizing committee of today's conference. Let me first start by giving glory to Almighty Allah subhanahu wa ta'ala for making today's conference a resounding success. I convey deep regards and hearty thanks to our honorable chief guest, Mr. Chandra Shekhar, Special Secretary to Department of Rural Development and Panchayat Raj, Government of Karnataka. Thank you, sir, for accepting our invitation and for being here with us today, despite your busy schedule. I take this opportunity to extend my sincere thanks to the Director in Charge, Professor Ghulamuddin Sofi, sir, for all his support and encouragement. It would have been impossible to organize this conference without his support. Thank you, sir. I also wish to express my gratitude to Organizing Chairman, Professor Abid Ali Ansari, sir, for his minute-to-minute guidance and for encouraging us at every point of time in organizing this event. Words are not enough to thank his constant effort to shape this conference. Sir, we appreciate your keen interest and the key role you play in organizing this conference. An event of this dimension cannot happen overnight. It requires meticulous planning and execution and an eye for details. We have been fortunate enough to be backed by a team of proactive and dedicated organizing members. It is an immense pleasure to thank our organizing secretaries, Dr. Sadique Ali sir and Dr. Renuka ma'am, for the involvement they have shown, and the willingness they have expressed to take on the completion of tasks beyond their comfort zones. Thank you so much, sir and ma'am, for your untiring efforts. It is my pleasure to thank our coordinators, Dr. Abdul Azeez sir and Dr. Azizur Rahman, for their contribution and support at every stage. I extend my heartfelt gratitude to all the speakers for sharing their time and valuable knowledge with us. I am very thankful to the HODs, faculty members, hospital and other non-teaching staff for their contribution and support. I convey my special thanks to Dr. Wasim Ahmed sir and Dr. Sharik Shamsi sir for their unwavering support to organize this conference. I take this opportunity to extend our most sincere thanks to all the delegates and the online participants who joined us today. Thank all of you for becoming a part of today's conference. I'm immensely thankful to the anchors who handle the stage proficiently. I extend special thanks to the PG scholars of Department of Ilmul Amraz for their efforts and dedication. Finally, I'm thankful to all the technical and supporting staff for their services. Thank you one and all for making this conference a great success.